take control of everything we'll do. At the end of the day, your name will be glorified in Jesus' mighty name. Once again, welcome. Without much ado, I want to invite our dear MD and Chief Executive Officer, Dr. Oluyemisi Bero, to give her welcome address. You're welcome, ma.
Good morning, everyone. It is my pleasure to welcome you all to this special discourse to mark the 10th year anniversary of the ARC. As we all may know, the ARC commenced full services in March 2012 with a focus and goal on providing cutting-edge fertility care in an environment that supports patients' needs spiritually, emotionally, and financially, which is a slight departure from the traditional medical care made that only addresses or concentrates mainly on the physical aspects of treatment. We have a rigorous client-centered approach with high technology and a high-touch care. The business philosophy of the ARC is to consolidate our knowledge of reproductive health and our belief in God as the only and sole creator of life in achieving our unprecedented results and performance. Our mission statement at the ARC is that we will do everything possible to enable every couple that visits the ARC to experience the joy of parenthood. And the vision is to be an outstanding example of how infertility treatment can be delivered efficiently, professionally, cost-effectively, and with compassion in a manner that exceeds the expectations of all parties involved. The ARC has since recorded greater than 500 live births since inception, with many ongoing pregnancies at present. I welcome you all. I welcome our dear Dr. Ibrahim Wada, the president of AFRH, our eminent speakers who are here to share their knowledge and vast experience with us today. To our dear colleagues and guests, on-site and online, you are most welcome. Thank you for taking time out of your busy schedule to spend the day with us. I believe that at the end of this special event, everyone would have learned a thing or two that would improve your practice as a fertility expert. Once again, I welcome you all. Thank you. Sit down and enjoy the ride. Thank you.
Thank you, ma'am. So thank you very much, Dr. Bero, for that wonderful speech. So we'll start with our very first speaker. His name is Dr. Mohan Raut. Okay, he's an eminent fertility specialist in India, and he'll be joining us all the way from India. He'll be talking about recurrent implantation failure, the role of intravenous immunoglobulin. And I'm excited because as practitioners, we face this kind of no failure. We're faced with a challenge when we have patients repeatedly having failed IVF cycles, and it can be very embarrassing to the doctor. So today I believe that Dr. Raut will be able to give us some of the tips that will help us improve our practice of this very disturbing challenge. Dr. Raut, you're very welcome, sir. A round of applause, please. Our online audience, please just welcome him. Type welcome, Dr. Raut. We love you all the way from Nigeria. Please do that. You're welcome.
Thank you very much. Thank you all for allowing me to be here on this special occasion. It is indeed my pleasure and a great honor to be here at the 10th year anniversary symposium arranged by Alpha Assisted Reproductive Clinic from Nigeria and to share this podium with stalwarts in the field of IVF, like Dr. Manish Banker, Dr. Human Fatemi, and Dr. Wada. So I will start sharing my screen. So the subject on which I am going to talk today is little unusual. This is usually not covered or not included in IVF seminars or IVF symposia, but it is a very important subject in this field, and it's a useful modality in the treatment of certain difficult to treat patients in this field. Yes, today I am going to speak on a subject called reproductive immunology, a novel approach in management of unexplained reproductive failure. The subject which is mentioned in the brochure mentions about repeated miscarriages and infertility. So I am taking a liberty to club that thing into reproductive failure, and we will see how reproductive immunology plays an important role in these conditions and whether we can provide a solution for these difficult to treat patients with the help of reproductive immunology. Before I start, I would like to express my gratitude to my parent institute, alma mater, State GS Medical College and KEM Hospital in Mumbai, India. Our teacher, Dr. Usha Krishna, because of which we are in this field of reproductive immunology, and my wife, Dr. Mugdha, who is a member of the Education Committee of American Society for Reproductive Immunology, for her help and support. So my talk today, the scope of my talk will be like this. There will be 6 parts. Is there a need to improve the RPL or IVF results? If yes, are current strategies helping in that? If not, then should we consider alternative like the use of reproductive immunology and immunomodulation? And if so, why we should consider immunomodulation or immunotherapy? Next is, when should we consider immunomodulation, in which cases? The 5th will be, how can we do this immunomodulation? And last is, what is the recent evidence in the literature which will support us or which will tell us that this is a good method for treatment of these patients. So coming to the first part, is there a need to improve IVF or RPL results? All of you know that recurrent miscarriages are defined by there are different definitions. According to American Society of Reproductive Immunology, 2 or more miscarriages are considered as recurrent miscarriages, while ASHRAE considers it as 3 or more miscarriages. So at any time, the women affected by repeated miscarriages can vary from 0.5 to 2%, and in certain studies, they have said it may be up to 5%. So the number is really huge. There are different causes of repeated miscarriages. I am not going into the details, but the important thing here in the slide to notice is that in 50 to 60% of these couples, all these factors are normal and they're called as unexplained miscarriages, and then the couples are handed over to nature, and it is in these couples that there can be underlying immunological factor. Coming to the IVF, the situation is similar. This slide a little old, but it depicts the success rate or the take-home baby rate in case of IVF, and this clinical pregnancy rate is shown as around 35 to 36%. Over these many years, there might be some increase in this, but still there is a large number of patients who are yet fail in IVF, because as this large cohort study of more than 100,000 women, it showed that after first complete cycles, 8% women undergo miscarriage, only 29.5 or close to 30% women have at least one live birth. Looking at what happens exactly at the time of implantation, this slide depicts the various phases or stages of implantation, where when the embryo comes in contact with the decidua, the first is the phase of stage of apposition, then the adhesion, third is invasion, and fourth is decidualization. At each of these stages, there is an interaction between the fetal cells as well as the maternal cells, and the outcome of these interactions decides whether the process of implantation is going to be successful or it is going to fail. You all know that implantation is an inefficient process. The maximum implantation rate, as shown by Reinhardt, is close to say 40 to 60%, and as the age advances, it still goes down further. So the implantation failure rate in ERT can be conveniently tabled as 40 to 60%. And what is recurrent implantation failure? There are many definitions, but the commonly accepted definition of Kaplan is recurrent implantation failure is failure to achieve clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in a woman under the age of 40 years. And very important to know that it is estimated that approximately 10% of women who are taking IVF treatment will land up with this problem of recurrent implantation failure. There are many causes of recurrent implantation failure. Again, I am not going into the details like the anatomical defects, the endometrial problems like thin endometrium, embryo-related problems like genetic abnormalities, but still there is a large percentage of patients who come into the group of idiopathic or unexplained recurrent implantation failure. And it is in these patients that there is impaired immunological interaction between endometrium and embryo as the underlying cause. So yes, there is a need to improve the results. Now, what are the current strategies? Whatever we are doing is helping in that. Let's have a small look at that. If you see the incidence of miscarriages, as the number of miscarriages increase, the incidence of miscarriage goes on increasing. After 3 miscarriages, it is around 33%, which increases to 60% after 4 and close to 80% after 5. So this is in spite of treatment. So still there is a large percentage of patients who fail to the treatment. Coming to the IVF, recurrent IVF failures or implantation failures, we have to focus on the seed, soil, as well as environment. And in the evaluation of patient with unexplained recurrent implantation failure, it is now shown that there is progesterone resistance, shifted window of receptivity, decreased integrin expression, and most importantly, immunologic disturbances. They have to be considered when you evaluate these patients. I'm not going into the details of the strategies, but one very important article I would like to share with you from Human Reproduction by Koot, and it is about what is the prognosis for a live birth after unexplained recurrent implantation failure following IVF or ICSI. And the study article says, because it surveyed that in that article, the 118 patients with recurrent implantation failure, which were defined by failure to conceive after 3 embryo transfers, they found that only 49% of the patients ultimately achieved live birth after 5.5 years. So this means that more than 50% patients of recurrent implantation failure fail to have a baby, fail to complete their family goals after 5.5 years. That's really a huge number. So still recurrent implantation failure is an enigma, and we have to look for alternative solutions. Then what is the alternative solution? Can immunology be an alternative to this? And immunotherapy or immunomodulation, can it be considered? So let's see why we should consider that before going ahead with how we can do that. And to understand that, we have to go back to Sir Peter Medawar, who is he was a Nobel laureate and who is considered as the father of reproductive immunology. And he, for the first time, put forward this golden question: how does a pregnant mother manage to nourish within herself for many weeks and months a fetus that is antigenically a foreign body, isn't it? Because we have an immune system which protects us, which protects us against any invaders, against bacteria, viruses, harmful chemicals. And this is done by a network of cells, tissues, organs, and certain chemicals like cytokines and chemokines, so that we are protected from the foreign invaders. But yet, this powerful defense system is overcome in mammals during pregnancy, where the fetus grows in mother's body without any problem. And this is because of the 2 parts of the immune system compared to the yang and yin of the immunological system, like the immunological destruction or the destructive part, which is important for taking care of the pathogens, and the tolerant part or the immunological tolerance, which helps to protect self and allogenic and other antigens. So the destructive forces of the immunological army are balanced by the second arm of the immune system, protecting the self, that is our cells, as well as allogenic part, that is the fetus, from immune responses. And this immunological equilibrium is very important for protection against our autoimmune and alloimmune responses. And any disturbance in this will lead to alloimmune or autoimmune disorders. And in last 25 years now, it has become absolutely clear that a large percentage of these unexplained reproductive failures can be due to alloimmune cause. It has been seen that as the number of miscarriages increase, the chance of alloimmune factor as the underlying cause also increases. This is because fetus, all of you know that fetus is a semi-allograft. The embryo and the gestational tissue express foreign antigens which have come from mother and the father, and the fetus gets 50% of the MHC genes from a genetically totally different father. The fetus is termed as a semi-allograft, and in spite of being a semi-allograft, the pregnancy continues without any problem. And this is indeed a paradox of pregnancy. In case of IVF, in case of donor embryo, donor egg, the pregnancy is 100% different. Still, it continues without any problem. This has been nicely explained by Professor Kwak Kim in a review article in Frontiers of Immunology, how different cells take part in this protection process. And she says that the T regulatory cells are the most important part. In the initial part of implantation, it is the Th1 type of cells which help in regulating trophoblast invasion, tissue remodeling, and angiogenesis. But this is further supported by the Th17 cells and Th22 cells which protect from pathogens. And as the process of implantation progresses further, the Th2 response comes into action, which promotes allograft tolerance and helps in preventing the implantation failures. So the differentiation of Th1 and Th2 type cells is important, but it is irreversible. The Th1 cells are inflammatory, Th2 are anti-inflammatory, but they are irreversible. So the two important cells in maintenance of pregnancy are the Th17 cells and T regulatory cells. Th17 cells are pro-inflammatory, while T regulatory cells are anti-inflammatory or suppressive, and they are less stable and they are interconvertible. And it is this part which is utilized in process of immunomodulation, because they can be interconvertible when environmental conditions change, and therefore this can be used for immunomodulation by using immunomodulatory agents like lymphocyte immunization or other immunomodulatory agents to convert Th17 cells into T regulatory cells, the inducible type of T regulatory cells which help in protecting the pregnancy. So yes, immune system, reproductive immunology is very important. Immune system plays a very important role in maintenance of pregnancy and implantation. But coming to the clinical part, when will you consider a particular couple as a patient for immunomodulation? How will you clinically select a couple for immunomodulation or immunotherapy? And for this, we take help of certain investigations. So these investigations are like lymphocyte cross-match or LAD, natural killer cell estimation from the peripheral blood, natural killer cell estimation from the endometrial lining, estimation of T regulatory cells, estimation of inflammatory cytokine, TNF-alpha, Th1, Th2 cytokine ratio, and certain other genetic tests like PHLA, DQ, KR, genotyping, and others. The famous systematic review and meta-analysis by Seshadri and Sankara in Human Reproduction Update showed that there is increased peripheral blood NK cell number in repeated miscarriages, as well as increased peripheral blood NK cell percentage in repeated miscarriages patients. Even an article by Azargun to know the importance of natural killer cells and their cytotoxicity in reproductive failure, it showed that the increased percentage of CD56 natural killer cells in patients with unexplained infertility, elevated expression of CD69 on natural killer cells, and high level of perforin CD50 cells in RPL is commonly seen in patients who have reproductive failure, and these can be utilized to select couples who will be benefited by immunomodulation. Coming to the endometrial NK cells, which are more important, natural killer cells in the uterine lining or endometrium play a very important role in implantation and maintenance of pregnancy. But excess concentration of activity of uterine NK cells has shown to be associated with reproductive failure. The endometrium has CD56 dim type of cells present normally, and they're very important for implantation process. But sometimes these cells maturate into what are known as the CD57 positive cells. And these CD57 positive cells are highly cytotoxic and are detrimental to pregnancy. And these cells can be estimated by simple endometrial biopsy and immunohistochemistry tests. So they can cause RPL or RIF. There is also importance of ratio of CD57 cells to CD56 cells. This original article showed that the ratio of CD57 cells to CD56 cells in the peripheral blood and endometrium is found to be raised in women who have recurrent implantation failure because of immunological factor. Also, there is associated decrease in T regulatory cells. One more test is KIR genotype. This is a specialized test. The functional activity of natural killer cells is regulated by certain receptors on their surface. They are called as killer cell immunoglobulin-like receptors or KIR receptors, and their interaction with the class 1 HLA expressed on embryonic cells determines whether the pregnancy will continue or there will be reproductive failure. The natural killer cells contain different types of KIRs, and some of them are inhibitory and some of them are activating. So if the KIRs that cause inhibition, inhibitory KIRs are activated, then they produce soluble factors and protect pregnancy. So testing for KIR genotype is also a helpful test to find out couples who will be benefited by immunomodulation. Next test is the lymphocyte cross-match. It is the lymphocyte antibody detection test, and it measures the amount of antibody that reacts with the proteins of paternal lymphocytes. And this test is used as a test to select couples who will be benefited by active immunomodulatory treatment of lymphocyte immunization. And a negative cross-match indicates that the immunotherapy will be beneficial in a particular case. Estimation of a cytokine, inflammatory cytokine TNF-alpha is also important. High levels of TNF-alpha are detrimental to pregnancy, and it has been found that women who have multiple failed IVFs, the TNF-alpha levels are invariably high, and they affect the implantation and as well as process of placentation in the early pregnancy. Estimation of T regulatory cells. Sorry. T regulatory cells, as I said, play a very important role in the implantation process as well as maintenance of pregnancy subsequently. And good level of T reg cells are essential to prevent even production of autoantibodies, and they're to see that the response is the T regulatory cells are increased, and then subsequently pregnancy can be planned. So yes, we can select couples using these tests. But what will we do with these patients? What are the different ways by which immunomodulation fail miscarriages? And there are various modalities of giving immunotherapy, and some of which we are already giving inadvertently. But I would like to stress upon a few about which we have experience. The first immunomodulatory therapy that was recommended for repeated miscarriages was active immunomodulation using lymphocyte immunization therapy. And I will elaborate a bit here because we have a large experience about this over the last 25 years. How does it act? It acts by producing blocking antibodies. These are asymmetric antibodies which help in protecting pregnancy. Also, it leads to Treg cell activation through dendritic cells. What exactly happens is when lymphocytes are injected intradermally, they are picked up by dendritic cells and presented to the immune system of the mother, which leads to activation of two types of responses, humoral response and cellular response. Humoral response leads to production of blocking antibodies, and cellular response leads to activation of lymphocytes with differentiation into regulatory cells which protect the pregnancy, preventing either implantation failure or a miscarriage. This is a daycare procedure. We have a special patented protocol which we do at our center. So it's a single seat procedure. Husband's or donor's blood is collected, lymphocytes are separated by a special process, and they're injected intradermally. Prior immunological testing is done to select the couples who have the maximum chance of benefit. Prior infection profile is done to prevent spread of infection and blood group to rule out Rh negative patients. The couple is asked to plan pregnancy after 4 to 6 weeks over next 18 months. Booster dose may be given during first trimester, and LIT can even be given during pregnancy, especially if the patient presents with pregnancy and history of multiple miscarriages in the past. It's a safe method in minor allergic reactions or occasional minor side effects, but there are no serious allergic reactions like anaphylaxis or graft versus host disease or autoimmune disease. In fact, there is a large study by Klinic from Germany of 4,500 cases of LIT who were followed up, and there was no specific risk for anaphylaxis, autoimmune disease, or graft versus host disease was shown. Yes, LIT, lymphocyte immunization therapy, had its own challenges. There was a study which came out in 1999 called REMI study by Ober, and this study said that immunization with paternal mononuclear cells does not improve pregnancy outcome. In fact, the study showed that the control group had 65% success rate, while the treatment group had only 46% success rate, and it was published in Lancet. But later on, it was found out that this study had a lot of irregularities or a lot of flaws, and this is the only study till date which has shown a negative effect of LIT. And the most important objection to this study was the lymphocytes that were used were stored for a long time, and this caused loss of their immunomodulatory effect, because it was shown by Professor Clark that the immunomodulatory effect of lymphocytes is because of the surface antigen, the surface marker called CD200. And when these cells are stored, this surface marker get destroyed and the immunomodulatory activity is lost. And therefore, in that study, the effects were poor. Also, this study did not exclude patients with autoimmune disorders like positive ANA, which also adversely impacted the results. Also, there were other problems, like there was no post-immunization control of immunomodulation. The lymphocyte concentration was not uniform. The doses were not uniform. But the subsequent Cochrane reviews which came after that were highly based on this study, and they recommended that immunotherapy is of no use. Paternal cell immunization, third-party leukocytes, IVIG are of no use, and the analysis showed an odds ratio of only 1.22. However, it is very interesting to note that there were many flaws in this Cochrane review itself, which were put forward by Dr. Christiansen from Denmark. Like, many important parameters were not considered by the Cochrane review, like the type of miscarriage, whether primary or secondary, multiple or number of miscarriages, immunization dose, routes of administration. So a lot of objections were created against Cochrane review. So there was a reanalysis done without Ober study, and if the odds ratio shot up to 1.6. But more interesting are the recent meta-analysis in 2016 and 17, where more recent studies were included, and the Lewis meta-analysis showed an odds ratio of 4, which proved the efficacy of lymphocyte immunization therapy beyond doubt. And in 2017, the next meta-analysis by Cavalcanti included even the Ober study, but still the odds ratio was 3.13, which underlined the efficacy of the lymphocyte immunization therapy. And these two meta-analyses showed that LIT is a safe treatment. It is a valid treatment for patients with miscarriages. It is beneficial when given before and during pregnancy, and the best results are obtained when there is adequate number of lymphocytes which are given intradermally. And the most important part was it is beneficial in well-selected couples, that is, the selected subgroups. One more important nice study I would like to share with you briefly. This is about study of more than 1,000 patients with repeated miscarriages who were analyzed or who were studied. And the interesting part was these, because the patients with repeated miscarriages have other factors also with them as a cause of miscarriage. So these patients were divided into 4 categories. One was only alloimmune.
so much, Dr. Rout, for that very, very interesting discussion. Well, I believe most people are like me. I have a lot of questions because we've been faced with this challenge in practice. So I'll start. Online audience, questions are welcome. Please type in your questions. And for those physically present, we'll take your questions if you have any. I'll start with myself. In our environment, Dr. Rout, you listed some of the tests or investigations we can do for those with recurrent implantation failure. But here, we don't really have access to those tests. And if we do, they're going to be very pricey. So I wanted to find out, is there anything from the history of the patient that could suggest that this couple or this particular woman will benefit from some of these therapies?
Sure. I think very good question, because we also face the same problem in our country. We also have problems related to the costing of the investigations, availability of the investigations. So yes, history is very important part. So a little detailed history will help us in pinpointing or selecting at least those couples who are more likely to have this immunological problem. The first and the most important thing is you are ruling out all other factors. So all other factors are ruled out. That is one definitely one factor. But in cases of, say, repeated miscarriages, a few important tips which we can have is a patient who has recurrent miscarriages which are say before 8 to 9 weeks, before 9 weeks, and without the cardiac activity. Many of them are likely to have immunological problem. But more important than that, if we know we have the facility to do the genetic testing of the fetus or the products of conception, and if these are genetically normal, then that is one more factor which can decide whether these patients have immunological problem. But otherwise, it is very difficult to say just from history that this patient will have repeated miscarriages. But important thing will be patient will keep on having miscarriages. You rule out all other factors, everything is normal. And so these are the couples who are more likely to have immunological factor as a cause. Second thing is, usually this type of alloimmune problem goes hand in hand with autoimmune problem. So presence of even autoimmunity, even in presence of autoimmune problems like the antiphospholipid syndrome and related conditions, there is increased chance of association with the alloimmune problem. And so many times we see that we treat this autoimmune problem, we give them low dose aspirin, we give them low molecular weight heparin, and still they keep on miscarrying because their underlying alloimmune factor has not been corrected. So some of these things in the past history, if we elicit in detail, we will definitely get clues as to whether this immunological problem is there. And regarding the investigation, I would like to share one thing, because we have also, I mentioned a list of investigation, all these are not available with us in India. We do 3 specific investigations like the lymphocyte cross-match, the natural killer cells in the endometrium or in the blood, and the TNF-alpha. And these are relatively simpler tests with which we have started. We still can't do the T regulatory cells or more advanced tests. So these tests are easy to establish. And if there is a center which deals with organ transplant, then most of these tests are available in the labs, where in the hospitals where organ transplant is done. So these investigations will be easily available, and it's not necessary that we have to do all these things. But yes, I agree that these are little costly, but then we have to see with respect to what, compared to what the cost is, and take a call.
Okay, thank you very much. Dear audience, any questions?
In the chat box, I am seeing one more question. Yes. So can I take that?
Yes, please. How is intralipid given?
Yeah. How is intralipids given? Yes. As you know, intralipids is basically a fat solution with soya and fat, egg yolk, which is otherwise used in total parenteral nutrition in patients who are in the ICU where they are not taking anything orally. But it has been found out that this particular solution also has immunomodulatory effect. and it decreases the activity of natural killer cells. So this is, in India, it is available as 20% solution. So 250 ml 20% solution, and this is used as an intravenous infusion. Now, in a patient who has recurrent IVF failures, this is given at the beginning of stimulation. Then then around the time of embryo transfer, maybe on the day of embryo transfer. So these two infusions are given, say, at the interval of 15 days. And once the test comes positive, then given, and then can be repeated every 15 days. Preferably, this can be continued till up to 20 weeks if it is possible. And this is given slow IV infusion over 1.5 to 2 hours, looking for allergic reactions, because they are known to have, intralipids are known to have allergic reaction because of the egg yolk which is there inside. But yes, with proper precautions, you can give this to many patients. It is cheaper compared to the other alternative, that is the intravenous immunoglobulins. The effects are, we have found it similar, so we have stopped using IVIGs. We use intralipids for these patients.
Okay, thank you for that question. Any more questions? I have anyway. Okay, there's another question here. Thank you for your presentation. Please, is there any relationship between PCOS and recurrent implantation failure? Secondly, how do you manage a woman less than 35 years with recurrent miscarriages, clinical pregnancies up to 4 times following IUI?
Yeah, first I think we will talk about PCOS. Yes, PCOS has been known to be associated with increased incidence of miscarriages. It is known. Firstly, PCOS is associated with a lot of hormonal imbalance. And the distinct hormonal imbalance is related to the androgens. They are associated with high levels of androgen, and these are the high levels of androgen are responsible for the symptoms and signs of PCOS, and also they are responsible for the pregnancy loss that occurs after along with PCOS. Also, the quality of egg which is seen in PCOS is, though there are a lot of eggs, the quality of individual egg may not be good. So again, they have been associated with miscarriages, which can recur and can or cause implantation failure. It's basically because of the and the one more fact, yes, it is the insulin resistance. PCOS is associated with insulin resistance, and that is an important factor which contributes to the implantation failure. So, doing fasting insulin before in patients of these recurrent implantation failure is very important, even without PCOS. And secondly, the next question is a woman with 4 chemical pregnancies. Yes. Following IUI. Yes, whether these miscarriages were natural or following IUI, the management, yes, is a patient with recurrent miscarriages. And as you are aware, chemical pregnancies are now considered as a clinical miscarriage, and because they affect the prognosis of the subsequent pregnancies. And the management is a long process actually. So first thing, we'll have to investigate this couple to find out the underlying cause. And you correct that underlying cause. If all those factors are normal, we investigate the couples for the immunological factor. And then most of these couples, when the immunological factor is present, we use active immunomodulation using lymphocyte immunization therapy with a special patented protocol that we have, so that it's a single sitting process. And after that, when the patient conceives, the patient is put on passive immunomodulation using different passive immunomodulatory agents like intralipids, and certain cases steroids, and even immunomodulatory agents like hydroxychloroquine.
Thank you very much. I know our time is fast spent, but I still just have one more question. We actually have a patient that had 2 miscarriages. The first cycle she had ended up with a blighted ovum. She had intralipids then. The second cycle, she had both intralipids and IVIG, but we ended up with spontaneous miscarriage at about 9 weeks. She started another cycle right now. Any tips for us?
2 miscarriages.
Yes, 2 miscarriages now.
Yeah, I could not hear in between.
Okay, the first IVF cycle. Okay, the first IVF cycle ended up with a blighted ovum, and she had intralipids. Okay. The second IVF cycle ended up with spontaneous miscarriage at 9 weeks. She had both intralipids and IVIG. Any tips? Because she's presently on stimulation.
Okay, so since she has conceived both the times and the implantation is proper, so if the second miscarriage, if the products of conception were tested for immunological problem, then for genetic problem, then yes, if that is normal, then it straight away takes us to immunological factor. And then such patients are investigated for immunological factor using lymphocyte cross-match, which is a simple test. And if it is negative, we select the couple for immunomodulatory treatment, the active immunomodulatory treatment of lymphocyte immunization therapy. We give this after 4 weeks. We ask them to plan the next IVF cycle. And because in spite of using passive immunomodulation, she has miscarried. So the treatment that she requires is active immunomodulation, and the passive immunomodulation works only after active immunomodulation is done with lymphocyte immunization therapy. We have so many patients, a series of patients now who have been treated with all the immunomodulatory agents and they have failed. And after LIT, lymphocyte therapy, the pregnancies are continued without any problem. So yes, you have to consider active immunomodulation in these patients. Yes, the patient has conceived, so that's a good thing. Patient is likely to conceive in the next cycle also. But to prevent the chance of miscarriage, immunomodulation is a must.
Thank you very much, Dr. Routs. Left to me, I still have a lot of questions, but I have to respect myself. So thank you very much. Ladies and gentlemen, let's give our speaker a round of applause. So before I go to the next agenda item...
thank you, everyone.
I'd like to acknowledge the presence of Dr. Ike Tubosun, past president of AFRH. You're welcome, sir. And also Mrs. Fumi Shokumbi, who is representing the Permanent Secretary, Lagos State Ministry of Health. You're welcome, madam. So we'll be having the first presentation by a presentation by one of the pharmaceuticals, Ferrin Pharmaceuticals, represented by Mr. Kess. So, Mr. Kess.
Good morning. Please permit me to establish protocols. The celebrant, Dr. Barrow, President AFRH, Dr. Wada. Okay. Dr. Wada Ibrahim, OON, former President AFRH, Dr. Ike Tubosun, Chief Executive Officers, distinguished fertility experts, and of course, gynecologists. Ladies and gentlemen, my name is Abanom Kesena, and it's my pleasure to be here, and I'm here with my team, person of Isugi, Egwa, and of course, Nkese. So very briefly, I want to congratulate the ARC. 10 years anniversary is not a joke. On behalf of Ferrin, we want to say big congratulations. It's been a decade of togetherness, to oneness. Anybody who visits the ARC can always tell that. Congrats, ma. Okay, next slide, please. So Ferrin is a research-driven biopharmaceutical organization, and of course, we are leaders in reproductive medicine and maternal health. Very briefly, I'll be taking you through a short presentation on menopause. Next slide. Now, the question is, not all gonadotrophins are created equally. We like to say that we are different from other HMGs and recombinant FSH. And why do we say so? It details it in our production. Basically, menopause is HCG-driven LH bioactivity, 75 unit IU of FSH, and of course, 75 IU of LH. But it's interesting to know that 75 IU of LH is actually derived from LH, from HCG. So we say HCG-driven LH bioactivity. And also, the HCG that we have in menopause is just about 10 international units, not the kind of HCG used for trigger, which is 5,000 to 10,000 international units. Now the question is, why have we taken the pain to actually put HCG in our molecule? Next slide, please. It's interesting to know that this is the MERIT study. Now, MERIT was comparing menopause versus recombinant FSH in vitro fertilization. On day 6, this study actually found out that it was HCG that was directly related to live birth rates, not LH. And the brain also releases pulsatile levels of HCG in addition to FSH and LH. And this is in the natural cycle. Next, please. Also, why is it important to actually have LH bioactivity in your stimulation? There are several schools of thought that says it's actually okay to use just one particular protocol, maybe recombinant and all of that. Now, this study was done by Westergaard, and he used 0.5 IU per liter on day 8 to actually distinguish patients who had low LH and patients who had normal LH. So patients who had less than 0.5 IU actually had low LH. And this study actually found out that there was a 5 higher risk of early pregnancy loss in patients who had lower LH. So this underscores the importance of having LH bioactivity early enough in your stimulation. Next, please. What about batch-to-batch consistency? There's been lots of papers to say that the urinary gonadotrophins don't give you as much batch-to-batch consistency as recombinant FSH. Now, we actually have to say that human-derived gonadotrophin have been demonstrated to be safe and as determined by a long period of clinical use, right? And menopause, of course, has proven efficacy in large clinical trials. This was also further endorsed by ESHRE. Now, beyond the endorsement by ESHRE, next slide, please. Claudio Wolferson in 2005, as far back as 2005, actually did a study, and there he found out that even menopause, a urinary gonadotrophin, gave you comparable batch-to-batch consistency with other gonadotrophins, whether it was filled in mass or whether it was filled by biopsy. And he proved that and also said that there was little or no study to show the contrary. Next, please. Now, I want to bring you to a very recent study done in 2020. This is actually a public document where menopause was compared with recombinant FSH using an antagonist protocol, right, for in ICSI procedure and with a single embryo transfer. So let's talk about the inclusion criteria. Next, please. While it's coming up, we also had, this study is a randomized control trial, assessor blind, open label trial too, and we had over 620 patients in this trial. So what were the inclusion criteria? We had women aged from 21 up to 35 years of age, for menstrual cycles up to 45 days, right? Normal testosterone. But what I really want us to see here is the AMH value. The AMH value was up to 35.7 picomole per liter, and of course 5.0 nanogram per ml. So this shows that this study was done specifically on hyper responders, right? And of course inclusive of PCOS patients. Next, please. So while the slide is coming up, we just want to show previous one. There's one before, please. Yes, we just want to show the protocols, right? So here, menopause or recombinant FSH was started 150 IU, right, for the first 5 days, and of course the dose was adjusted up to 75 IU depending on the need of the patient. Once the follicle reached about 14 millimeter, right, of course your GnRH antagonist was used, right, and the HCG was also employed for trigger. But to reduce the incidence of OHSS, now, and being that this is an antagonist protocol, once you had 3 follicles above 17 millimeter and you have your estrogen level above 5,000 nanogram per ml, instead of using your HCG to trigger, the GnRH agonist was used to trigger, of course, to reduce the incidence of OHSS. Now, let's see what the result look like, right? So this is just to juxtapose the importance that even in an antagonist protocol, your menopause is also the gonadotrophin of choice. So next slide, let's see the results. So now, in menopause, we don't talk about lots of eggs, right? So interestingly, this result, you see that initially you had 15 oocytes for menopure and 22 oocytes for recombinant FSH. So it means that recombinant FSH had more oocytes, right? But the question is, did this more oocyte, did it translate to better ongoing pregnancies? Did it even translate to excellent blastocysts? So you see that as you move from the oocytes, number of oocytes, to the number of M2s, to the number of fertilized, to the blastocysts on day 5, excellent blastocysts on day 5, you see that the number has reduced and is no longer statistically, or it's no longer even significant, right? But now let's go further. Something interesting. Next slide. Now, why the next slide is coming up? What we found out actually was that despite the high number of oocytes, right? Next, please. Previous one. Next. Yes. So despite the high number of oocytes, what were the results? Live birth rates, right, for fresh transfer. You had 63.4 for menopure, and you had 50.8 for recombinant FSH. Now, if you look at this result, it is not statistically significant, actually. Numerically, the figures favor menopure live birth rates, but it's not statistically significant. Now, if you move, which is the point of interest, to cumulative early pregnancy loss, in frozen cycle, menopure had statistically significant less pregnancy loss. What about cumulative early pregnancy loss for both fresh and frozen? Menopure had significantly less pregnancy loss. So talking about pulling your miscarriages, pulling your biochemical pregnancies, pulling your abortions, right? So menopure, and of course in PCOS patients who are also hyper-responders, right? Menopure had statistically significant less pregnancy loss. This is a public data. You can always verify. Next slide, please. So just talk about the incidence of OHSS, right? Menopure also had statistically significant less OHSS. This buttresses safety, right, for both early OHSS, right, and for both all grades of OHSS. I'm sure safety is also something we want to see in our practice, right? And this also can be instrumental to the fact that menopure doesn't give you seemingly lots of eggs everywhere, because there are studies to show that once you are beginning to have more than 15 oocytes, the risk of OHSS already begins to increase. Next, please. So I'd just like to begin my summary is that, first of all, as a company, we are confident in our consistent pregnancy outcome, right? In our favorable safety profile, in the 2 decades of experience that we have. What about the outcome? Next slide, please. The outcome in terms of the top quality embryos that we have, in terms of the optimal endocrine profile, and of course live birth rates, which we are sure that you always want to see in your clinics. And lastly, is proven. As a company, highly scientific company, we are supported by 4 randomized control trials, systemic analysis, and we are present in over 130 countries. I'd like to say a very big thank you for listening, while I hand over the mic to my colleague for just a quick remark for ARC.
All right. Thank you so much, Kes. My name is Iesoge Agwai, and I'm the direct medical representative that liaises with the ARC. Over the last 2 years working with the ARC, I just want to speak to the positive culture that's there. I mean, from the moment you come through the doors, you can already feel, that positive energy. And, it's a beautiful thing that at the ARC, you're helping families you're helping build families, but also within your within the ARC, you've also been able to build a very tight-knit family, which is not something you find everywhere. So for that, I want to really congratulate Dr. Bero and the entire team. And we look forward to more milestones, more reasons to celebrate, and so much more success. Thank you.
Thank you very much, our dear Ferring Pharmaceuticals. We also appreciate you for your support. Next, we'd like to invite Mr. Olawale Ijaola, representing Merck, for a short presentation. Thank you.
Good morning to all our fertility experts. Good morning, Dr. Eketibosun, the past president of AFRH, and I'm sure Dr. Wada must be connected online. So good morning to AFRH. And then also, big congratulations to Dr. Adeyemi Bero for 10 years. When she mentioned it to me, I thought, I didn't believe it. I thought it was probably, it should be more than that because of how much the brand has delivered value over the years. So big congratulations to you. And it's a great privilege for us, Merck, to partner with you, not only in the use of the product, but much more in the belief in the product as well. And also standing here, representing Merck, we say once again, congratulations. I'll make my presentation quite short. Our focus is always trust matters when you are starting a family. And the whole ART outcome depends on the chain of variables, some that are within our control, some that we cannot control. Interestingly, in Nigeria, we have sound fertility experts. So what we want to do is just to support you with quality products that can help you to maintain the constant in terms of what the outcome will be. And so we know what the whole cycle of stimulation involves. We know what the target is. We know we're looking for the whole sites. We get fertilized and then it produces the embryos. And then ultimately, this leads to pregnancy for the patient. So in other words, we can say the more embryos, the more chances that we'll achieve pregnancy. So in the end, three key things that we'll focus on is the amount of drug used in achieving this pregnancy, the number of oocytes an embryo produced, and the cumulative chances of the patient to achieve pregnancy. So the journey for Merck, to let you know, we were at the beginning, from the days of Pegona and Metrodin. I'm sure Dr. Eketibosun will be familiar with those names from whole days of how we journeyed to the recombinant FSH, which is now the gonal F. And what was the objective for doing that is to achieve safety, to improve efficiency, and to improve consistency in what the results will be. So we know that when it comes to gonadotrophins, you basically have two sources. So that you are getting it from the human menopausal gonadotrophin, which is the HMGs, and also from the recombinant FSH, which is what we stand for. Okay, and then when it comes to luteinizing hormone, there is only one in the market, which is the recombinant LH, and that is coming from Merck. It's called Luveris. And then also we have the human chorionic gonadotrophin, the HCG, which is either extracted from pregnant women or also from the recombinant technology. So this is the raw material for the urinalysis, which we're quite familiar with. And then when it comes to recombinant, you are talking about DNA work here for you to achieve your result. What was the objective of recombinant FSH is to eliminate unwanted proteins, increase consistency in terms of results, and also improve the degree of specific activity. So at the molecular level, when you compare these gonadotrophins, first of all, we look at the level of purity. And because, the recombinant FSH, which is gonal F, you're getting it from recombinant technology, not through urinary. So you expect that in terms of purity, this will be very quite high. And this is confirmed in this study. Also, in terms of how it is filled, recombinant FSH, because it's not gotten through urine, is not filled by bioassay, is filled by mass. What does this translate to for the patient? It means that when you're talking about the level of variability, both in terms of purity and it's also in terms of the mode of filling, in terms of what you see in terms of variability is that you have, when it comes to the urinary FSH, the HMGs, you're looking about 2 to 25% variability in terms of batch-to-batch consistency. But when it comes to recombinant FSH, which gonal F stands for, you are sure of consistency in terms of batches that you are getting. Now, what does this translate to for the patient? It means when you have batches of variability, there will be days of good response, there will be days of bad response, there will be days of risk of OHSS as well. But when you're dealing with gonal health, what you have is you have consistency in what the batches will be. Now, what does consistency, the precision dosing from batch to batch, what does it translate to in terms of our treatment processes? One is when you have a more precise dosage, then you have uniformity in what the ovarian response will be. And when you have uniformity in ovarian response, you have fewer cycle cancellations and you have fewer need for dose readjustment. And that's what was confirmed in this study, available to us. So what does this translate to in terms of the ovarian axis? There are so many studies that has compared gonal F with the HMGs, and most of the study favors that when it comes to the number of oocytes, you are going to have more when it comes to gonal F. Also, in terms of the total dose, you see the study also goes on to say that you are going to have lesser usage of the FSH when you are switching, when you're using gonal F. And that's why the European Medicine Evaluation Agency in 2009 says in ART, gonal F at a lower total dose and shorter period than urinary FSH resulted in higher number of oocytes retrieved when compared to the urinary FSH. Also at the clinical level, from the Friedman study in 2000, we established that you have more oocytes, you have more cleaved embryos on day 2 per patient. So this also, from the same study, confirms that not only do you have more oocytes, you also have the days of stimulation also reduced from gonal F. You're seeing about 11 days. The total dose required also gets reduced when you're using gonal F to achieve the same result. And also the need to increase the dose also gets reduced for us. So at the ovarian axis, we know gonal F is proven to be more effective than urinary FSH alone, or in combination with what you have in the HMG to recruit more oocytes, more embryos, and with less total amount of the drug. And more oocytes and more embryos are correlated with cumulative chances of live birth rate and pregnancy rate. So ongoing pregnancy rate increases with the number of oocytes that you retrieved. Finally, I'll be wrapping up with this study from the German study with about 290,000 IVF patients treated with recombinant FSH or the HMG. And the outcome was that you have significantly lower cancellation rates and higher pregnancy rates. This is a study. You see about 6,700 pregnancies more with gonal F. You have the lower cancellation rate, and then you have the higher pregnancies available to you. Also, in terms of the drug usage, you have lesser dose of the FSH when you're using gonal F, and you have more live birth rate. Now, in our market, we've also know that not only do you have gonal F being the pioneer when it comes to recombinant technology, you also have the biosimilars as well. And this is where our campaign continues with the word you have to trust matters when you are choosing the brand, the product you want to use for your patient. A recent study from a meta-analysis in 2021 by Chua shows that when you compare gonal F with the recombinants, the biosimilars that you have across the globe, with gonal F, you're having more live births, more clinical pregnancy, and more ongoing pregnancy. And you agree with me, we're not just looking for oocytes, we're looking for babies. And this is what gonal F will give to you compared to what you have with the biosimilars and also with the HMG. So in summary, I'll say the reality is this. The total dose of the gonadotrophin usually are not being considered, but we should be considering it because it translates to cost for the patient. And this is what gonal F would give to you. You have lesser dose of the gonadotrophins when you're using gonal F. Why? The batch-to-batch consistency. Number 2, you have more follicles, you have more oocytes, more embryos produced. So, summary, you can say gonal F will give you the result by producing more for you with lesser dose of the FSH and lesser stimulation days. And also, when you compare it with the biosimilars, it's established from the recent meta-analysis that you are going to have more live birth rates with the gonal F. So with this, I say a big thank you to you. And don't forget, gonal F comes in pens, which makes it more convenient for you to be able to change the dose that you want to give to your patient. So once again, I joined every one of us here to celebrate with Dr. Adeyemi Beru for 10 years. And we look forward to 20 years, 30 years, 40 years, 50 years, 60 years, and you standing strong in good health with every one of us. Thank you so much.
Thank you, Mr. Ijeola, for that presentation. Thank you, Merck, for your support. Next, we'll skip the presentation by the third pharmaceuticals, please, because the second international speaker is already time. He has joined. Okay, please come, please come. All right, so we'll be having the third presentation by Joyce Emenemen from Alpha Pharmacy. Thank you.
Okay, good morning, everyone. I would like to stand on the existing protocols. I'd like to say good morning to all the fertility experts here present. My name is Joyce Emerenini, and I'm representing Alpha Pharmacy Limited. And here with me are my colleagues, Mr. Nonso and Mr. Obina, the team lead for fertility in Alpha Pharmacy. And we at Alpha Pharmacy would like to say a big congratulations to ARC on the 10th anniversary. We say congratulations to Dr. Beru, and we wish you many more years of productivity, many more years of positive impacts going forward. Okay, so Alpha Pharmacy, I would just like to talk to you about Alpha Pharmacy briefly. We are an indigenous pharmaceutical company, and we've been partnering caregivers for over 36 years now. And Alpha Pharmacy actually represents a number of international pharmaceutical companies, including Martindale UK, Rotex Medical Germany, LG Life Sciences in Korea, LD Collins UK, and so on and so forth. Next slide. Okay, so we partner specialists and anesthetics, obstetrics and gynecologists, nephrologists, and the rest of them. Next slide. Okay, so for the obstetrics and gynecologists, we have a number of products for these interventions. We have IVFM and IVFC, that's HMG and HCG. They are both produced by LG Life Sciences, the same company that produces your regular LG electronics. And then Folitrop. Folitrop is recombinant pure FSH, still produced by LG Life Sciences, Korea. And we have Lufex. Lufex is leuprolide acetate. We have other medications for the fertility experts. Next slide, sir. Okay, so we have Cyclogest. Cyclogest is the gold standard for the management of luteal phase. And then we have magnesium sulfates, Rotex, oxytocin, methyl-legometrin, and the rest of them. Next slide, sir. Okay, so coming to the subjects that we would like to briefly talk to you about today, effectual luteal management, helping deliver little miracles. Next slide, sir. Okay, so when you talk about luteal support, we all know why we need to support the luteal phase. Number one, you have higher live birth rates, and you have reduced pregnancy loss, and then there are generally better clinical outcomes when you employ luteal phase support. Next slide, sir. Okay, so you cannot talk about luteal phase support without talking about progesterone. And when you talk about progesterone, you talk about two things you really have to consider: the source of the progesterone and the route of administration. So you have natural progesterone, you have semi-synthetic forms of progesterone, and you also have the synthetic forms of progesterone. Next slide, sir. Okay, so when it comes to synthetic progestins, there are several drawbacks, and studies have recorded all of this. You can see my references on the slide. There are risks of virilization, that is the masculinization of the female fetus. And then you have a number of cardiovascular defects. And then you also have some forms of neural tubes defects, and then bacterial syndrome. All of these are references that are recorded in conjunction with the use of synthetic progestins. And when it comes to natural progesterone has no risk of interference with unborn fetus. And then natural progesterone was also associated with lower breast cancer risk compared to the synthetic progestins. Next slide, sir. Okay, so we want to talk about the difference today, and the difference is Cyclogest. Next slide. Okay, Cyclogest contains natural progesterone and hard fats from vegetable source. The progesterone in Cyclogest is obtained primarily from the plant source, and mainly soya and a specific species of wild yam. And the progesterone in Cyclogest is bioidentical with the endogenous progesterone. That is, the progesterone you have in Cyclogest is the same as produced by the corpus luteum and the placenta. That's the structure of the progesterone molecule, that's the endogenous progesterone. And on the right hand is please go back to the slide, sir. And on the right hand is the structure of Cyclogest. You can see that the structure of the endogenous progesterone and what you have in Cyclogest is actually the same. Next slide, sir. Okay, so indications for Cyclogest, luteal phase in supporting IVF, treatments of premenstrual syndrome, treatment of postnatal depression, and the management of threatened and spontaneous abortion. Next slide. Okay, like I said before, that when you are considering your choice of progesterone, you will have to consider the source, and you also have to consider the route of administration. Cyclogest is a target delivery system medication. Cyclogest pessaries are actually administered via the vaginal and the anal routes, and this actually makes for endometrial optimization. That means the medication is actually delivered at the endometrium where it is needed. Now, because it is delivered at the endometrium and it is given through the vaginal or the anal routes, Cyclogest actually bypass the hepatic first pass effects. Cyclogest pessaries avoids the first pass effect, and we know that progesterone as a molecule gets metabolized by the liver, and then several metabolites are being produced. One of the metabolites produced by progesterone when it is administered to the oral route is allopregnanolone. Next slide, sir. The allopregnanolone is a psychoactive metabolite that is associated with sedative effects on the CNS. Patients may report dizziness, somnolence, anxiety, bloating, and the rest of them. Next slide, sir. Okay, so dosage and administration of Cyclogest. Cyclogest is unique suppository wax progesterone pessary, and the melting range is between 36 and 38 degrees. Now, this ensures gradual melting with relative hydrophilic properties. And then there's a slow release of the progesterone, allowing for a twice daily dosing instead of 3 times daily with the other preparations. And there's no significant reduction in the levels of the progesterone between 4 to 12 hours after administration. And then Cyclogest is self-lubricating, aiding painless insertion. And I want to state that the insertion will have to be a high insertion. And then application is not painful and is not also messy as involved with other kinds of preparations. Okay, so Cyclogest is actually the gold standard for luteal phase management. It's an international brand. The trademark is actually available in over 100 countries, commercially available in over 50 countries. And a study was carried out in the UK, and it was found out that 85% of IVF clinics in the UK uses Cyclogest. And by 2020, it was recorded that over 1.4 million babies in the UK were already born with the assistance of Cyclogest. Next slide, sir. Okay, so cyclogest is given 400 milligram BD, gives an adequate endometrial response, and this was also studied in the UK, and about 94% of treated women had positive response. Next slide, sir. So side effects include local irritation by some patients, abdominal bloating, chest pain, and the rest of them. Next slide, sir. So when it comes to your choice of progesterone in the management of luteal phase, we'll actually like you to choose cyclogest, because cyclogest is actually the gold standard for the management of luteal phase. Thank you very much for your time. And before I hand over the mic, my colleague here, the head of fertility team at Alpha Pharmacy, would like to say a word to the Alpha.
Good morning. Good morning, everyone. All protocols duly and accurately observed. My name is Obinna Ekekwe, and I wrote a small poem for the ARC team. We respect, especially Dr. Berry. It's a very short poem because I know we're pressed for time. It goes as thus. It starts with 1, then a decade, then we aspire to a score. A century now looks like tomorrow. Through it all, we have forged families, joys, tears, and hope. But in all, we light the candle of hope. We wish the ARC family, Dr. Barrow, a happy 10th anniversary. Thank you.
Thank you, Merck. Thank you, Alpha Pharmacy, for the poem and also for reminding us about cyclogest. So our next speaker is the Managing Director of Nova IVF Fertility and Pulse Women's Hospital. He is the Chairman, Infertility Committee, Federation of Obstetrics and Gynecology, Societies of India. He's also the founder and board member of Aspire and a member of Draft Committee for ART Bill of India. He's no other person than Dr. Manish Baker. Ladies and gentlemen, let's give him a warm welcome. Thank you.
Thank you very much. It is indeed a pleasure to be a part of this scientific meet, celebrating the 10th anniversary of ARC Infertility Clinics, and my best wishes for a very successful decade and many, many more years to come. So the topic that I speak on that if I am starting my cycle, if I've initiated a cycle, what are my chances of having a live birth? So this live birth rate per cycle initiated, it is at 23.8% only. So the same scenario, you could report your pregnancy rate as high as 55%, or from a patient's perspective, it is actually only 24%. So let us now see then how does the world define success? Before that, two scenarios, two clinics treating 100 patients, both having a pregnancy rate of 50%, and which means that 50 patients would become pregnant at both the clinics. Are they both equally good? Let us see. Clinic A transfers 2 embryos in every patient. Clinic B transfers 2 embryos in 70% of its patients and transfers single embryo in 30% of the patients. So Clinic A achieves 50 pregnancies by using 200 embryos, whereas Clinic B achieves the same 50 pregnancies by using 170 embryos. this is very obvious that Clinic B is far more efficient than Clinic A. And this is what is meant by the implantation rate, that is the pregnancy achieved per embryo transfer. And this Clinic B now has 30 more embryos left, which could be used to achieve some more pregnancies. So let us pause for a moment and see then how does the world report success? Because you cannot have different clinics reporting different success rates when we go to the international registries. So the International Committee for Monitoring ART, where I am one of the regional representatives, we collect data from all over the world and publish it as the international report. And this report looks at a delivery rate per aspiration on a cumulative basis as a method of success. So this is a parameter which is now almost universally adopted, that if a cycle is counted, that when a woman initiates medications to start an ART procedure, and delivery of a child per initiated cycle is the only measure of the success. So the world reports success rate as cumulative live births arising from one egg collection process. And this has more or less standardized how success should be reported. And this helps us in comparing clinics and benchmarking our clinics with the rest of the world. Second, what are the major risks that are involved in this procedure before we view its successes? The four major risks are ovarian hyperstimulation syndrome, multiple pregnancies, maternal and perinatal morbidity and mortality, and congenital abnormalities. Now, ovarian hyperstimulation is purely an iatrogenic complication, and in the early days of long agonist cycles, the incidence was nearly 30-35%, 5% requiring hospitalization, and 2% requiring hospitalization. But with the advent of the antagonist protocol and an agonist trigger, this risk has completely disappeared. And this was the concept of an OHSS free clinic, which was promoted by Professor Paul Devroy. But the risk still persists. We have published case reports of severe ovarian hyperstimulation syndrome even after an agonist trigger. So whereas this significantly reduces the risk, it does not 100% prevent it. The second is the risk of multiple pregnancies. And if you look at most world registries, the pregnancy rates of twins and higher order are now falling below 10%. And in the more regulated countries that of Europe, they are falling to below 2-3%. But this is from the last database from the SARD and the CDC, the twins and the triplets pregnancy rates. So this has been a challenge because people tend to transfer multiple embryos with the hope that at least one of these multiple embryos would implant. But if you're tracking your implantation rates, you would know what is the probability of achieving a pregnancy per embryo. And if your implantation rates are improving, you can transfer fewer and fewer embryos, more so if you are transferring blastocysts. We also have evidence that instead of transferring two embryos at one go, if you transfer one embryo in 2 cycles, that is 2 elective single embryo transfers, it gives a higher cumulative live birth with a lower incidence of multiple births, prematurity, and low birth weight versus a single double embryo transfer. So there is a lot of evidence suggesting that instead of transferring higher number of embryos, you transfer one, you preserve the others, and you transfer them in a subsequent cycle. And then are the issues related to the maternal risk in terms of pregnancy-induced hypertension, diabetes, the risks related to operative delivery, and the neonatal risks of preterm and prematurity. And the last is the issue of birth defects. We know that infertile women per se are at a higher risk of developing birth defects. And there is a lot of evidence which suggests that doing an IVF or ICSI does not increase the risks of birth defects. And this is what has been published in the systematic review and meta-analysis, that doing ICSI does not increase the risk of congenital malformation. We have also proven and compared the congenital abnormalities in self-oocytes versus donor oocytes, and we have found that the congenital abnormality rates are similar in these two cohorts of patients. So then the question is, how do we achieve it? And I would start with, what are the optimum number of oocytes that we should be looking for? Now, this is an oft-quoted paper from Shesh Sunkara analyzing nearly 400,000 plus treatment cycles carried out in UK. And what she concluded was that the live birth rate plateaued at an oocyte number of between 15 to 20. And if the number of oocytes exceeded that, the cumulative, the live birth rate did not increase. And this led to the belief that the ideal number should be somewhere between 10 to 15. But this is looking at live birth rate following a fresh embryo transfer. And remember, the world now defines success as cumulative live birth from one egg collection. So what happens if you produce more oocytes? There is evidence that by producing a higher number of oocytes, you are not increasing the rate of aneuploidy. There is also evidence that the biochemical pregnancy rates, the live birth rates, are not dependent on the drugs. But higher the number of oocytes that you produce, higher is the likelihood of having more euploid embryos. And higher the number of oocytes that you produce, higher is the probability that at least one of this embryo would be euploid. So if we look at the cumulative live birth rate, looking at the patient's age, this is the optimum number of oocytes that one would need to have at least one euploid embryo. So the current thought process is that higher the number of oocytes you are able to produce, higher is the cumulative live birth rate. Does this mean that you have to act like cowboys and carry out completely unrestricted stimulation? No. The message here is that you should not understimulate a patient. You should carry out optimal stimulation. So which type of stimulation would you use? And to decide this, you look at the markers of ovarian reserve. And the important markers that are currently used are: one, the patient's age; second, anti-Mullerian hormone; and third, the antral follicle count. These three are the most commonly used biomarkers. AMH, it is fairly consistent and stable, but there are some variabilities even in the AMH levels depending on the biology, the exposure, and the laboratory method that is being used to measure the AMH. But if you use both AFC and an AMH, it is far superior than FSH and age, with a higher area under the curve for predicting both poor response and predicting excessive response. So today, in addition to age, which is the best indicator of quality for quantitative ovarian reserve marker, antral follicle and AMH are the two most commonly used parameters. So the question is now, how do you stimulate? Mild, conventional, or intense? And the answer is doing an optimal or a conventional stimulation. Because this particular forest plot, which compares mild versus the conventional stimulation, clearly shows that with the conventional stimulation, you will achieve a higher number of oocytes. Which type of downregulation will you use to achieve this? Both have their pluses and minuses. The long protocol requires more injection. It is less patient-friendly, but the biggest drawback is the inability of triggering with a GnRH analog if the patient requires an all-freeze cycle. Whereas the antagonist is more friendlier and you have the ability to give an agonist trigger. And the results now show that the live birth rates are comparable whether you use the agonist or the antagonist. And there is some evidence that the cumulative live birth rate is possibly better with an antagonist downregulation as opposed to the agonist. So intensity of stimulation has to be conventional. You should try to produce the optimal number of oocytes and try to create more embryos. The issue with higher stimulation is more related to the endometrial receptivity and not with the oocyte quality. Because when you stimulate the patient, there is evidence that increasing hormonal levels leads to advancement of the endometrium, and the endometrium may not be receptive if you are giving very excessive stimulation. So then this brings me to the next point, that should you then transfer the embryos in a fresh stimulated cycle, or should you do a frozen cycle? And if you want to do this, should we do a freeze-all for all our patients or not? Now, this all started with a few publications coming in the 2010 to 2015 period, which suggested that a freeze-all protocol was possibly better in most scenarios. And this all started with this meta-analysis by Matthew Rowe. See the number of studies. There are 3 studies in this particular meta-analysis. The first, alpha-thunian, the largest, having 374 high responders, and 2 others from Shapiro, which had 137 normal responders and 122 higher responders. But so large number of patients in this meta-analysis were high responders. Secondly, the largest contributor of this, the alpha-thunian study, was retracted subsequently. This whole meta-analysis is now not considered valid. However, the conclusions drawn by this meta-analysis started the whole frozen transfer fever. We then had a publication in the New England Journal looking at 1,500 plus PCO women, showing that the pregnancy rates were significantly higher at 49% versus 42%. But again, this was in women with polycystic ovarian syndrome. We then had 2 more papers, one looking at pregnancy rates in women without PCOS, and second is in normal ovulatory women. And both concluded that the pregnancy rates were similar following a fresh versus frozen embryo transfer. And then the Lancet publication looking at fresh versus frozen embryo transfer, a multicenter randomized trial, again, it resulted the frozen single blastocyst transfer gave a higher singleton birth rate. So this controversy primarily stems from the fact that each study is comparing different patient populations. There is now increasing evidence that if you do a frozen embryo transfer, it does not come without any risks. The risk of macrosomia, the risk for large for gestational age babies, the risk of placenta ecreta, need for cesarean or operative delivery, and the risk of preeclampsia is significantly higher with a frozen embryo transfer versus a fresh embryo transfer. So the question then is, what is the ideal time for doing a transfer? Should we do it for all patients or only for proper indications? Current evidence suggests that it should be restricted for appropriate indications. And this would mean a patient who is at risk of ovarian hyperstimulation, if the patient has premature progesterone rise, if the patient has an inappropriate endometrium, if the patient needs embryo pooling, if the patient is for pre-implantation genetic testing. But a normal responder would have an equal pregnancy rate with a fresh transfer as with a frozen embryo transfer. And last, we need to use appropriate technologies. And I shall look at it from 2 aspects. One is the endometrial receptivity assay, which looks at the endometrial receptivity. So this is based on the concept that the endometrial receptivity is not the same. That is, you need to transfer a blastocyst on day 5, but there is a window in certain patients. And this is all the more important in patients with recurrent implantation failure. And we have shown that in patients with recurrent implantation failure, in nearly 20% of the patients, this window of implantation is displaced, and you need to carry out what is called a personalized embryo transfer, which means transferring a blastocyst after 3, 4, 5, 6, or 7 days of progesterone, depending on the patient's receptivity. And in these patients who have an altered window of implantation, if you do a personalized embryo transfer, you will achieve good pregnancy rates. And secondly is the use of pre-implantation genetic testing. Essentially, what this does is helps us in screening the embryos and separating euploid and aneuploid embryos. And this will help us in deciding which embryos to transfer, and if so, which to transfer first. So it will improve the pregnancy rate per embryo transfer, but not per egg pickup. It will shorten the time to achieve a pregnancy because you will transfer only the normal embryos and not the abnormal embryos. And we have shown that this helps in improving or hastening the pregnancy. And if you look at an age-wise breakup, in younger number of patients, the percentage of normal embryos is nearly 88%, whereas in elder patients, this drops to 32%. But if you transfer this normal embryos only, the pregnancy rates are then the same across all age groups. And lastly, to achieve consistent and high pregnancy rate, you need an extremely good quality assurance and a quality control program in the entire IVF process, more so in the IVF lab. And let me take you the few basic steps that you need to install. The first is the process of what is called benchmarking. That is, you should compare your performance with that of the industry or the best practices in the society. For this, you can either use an external benchmark, which is an industrial norm, or you can use your internal benchmark. For the external benchmark, we have guidelines from ESHRE, we have guidelines from ACE, and you could use this benchmarks and try to see where your own laboratory performs. You should also look at your internal performances over a period of time, because there is no need to set, or it is not wise to set benchmarks which are unrealistic. You need to look at your internal performances, aim to achieve the external benchmarks, but do it in a phased wise manner. You would then need standard operating procedures for each and every step. And what does this actually mean? So this SOP actually communicates who will perform the task, what materials are needed to perform it, where will it be performed, when will it be performed, and how will it be performed. These are the 5 W's that we need to answer, and every clinic should have such standard operating procedures so that each step is done in a consistent manner. And then you need to decide what are the key performance indicators which you will monitor. This will tell you whether everything is working as it should. It will tell us whether you need to take certain steps if there is a problem. And this could be related to business aspects of your clinic. This could be clinical KPIs, or this could be purely embryology KPIs. You should define what you want to track, how you want to improve on all these KPIs. And if you're monitoring the lab, you need to monitor all the parameters. This is looking at the temperature graphs, the humidity graphs in the incubators, the temperature in each and every incubator. You also monitor the KPI of each embryologist. How is each embryologist in your lab doing? Because if the birth rate of your lab has fallen, unless you are monitoring the performance of each person, you would not know what to do and where to begin to improve this. The challenge sometimes is that if you have so much data, how would you interpret the data? For example, if you see that the average number of oocytes that you are collecting is increasing, this could be because one of the consultant has changed the stimulation program. This would also mean that you're putting your patients at a higher risk of ovarian hyperstimulation syndrome. This will also mean that there'll be more work in your lab, there'll be more eggs to fertilize, there'll be more embryos to store, and you will need higher manpower and infrastructure within your lab. This is a classic example of what we faced a couple of years back. The pregnancy rates dropped month on month, and we were clueless as to what to do. The first question was, when should we have pressed the panic button? Should we have done it when the pregnancy rates dropped from 47.8 to 42.9, or when it dropped from 41.7 to 36.1? And for this, you have what is called the Shewhart's chart. So Shewhart was an engineer who worked for the Western Electric Company, and he designed this kind of charts which shows whether the parameters are falling within plus minus 2 standard deviations. And it gave an idea as to what is the warning line and what is the control limit. So if you plot this on the charts, the earliest warning is at the level when it dropped from 42.9 to 41.7, and the panic button is when it had dropped at 36.7. Because unless you interpret this correctly, you will make changes when they are not needed, and you will be completely lost. So this forms a very important part on how do you give consistent improvement in the pregnancy rates. So the take-home messages of my talk: one should define success as cumulative live birth, healthy singleton live birth from an initiated cycle. We should carry out what is the conventional or optimal stimulation, generally with an antagonist protocol. You do an all freeze in an appropriately selected patients, not for all, and you should use technology for the appropriate indications, and you must have robust QA/QC protocols in your lab. Once again, I would like to thank the organizers and would like to wish the Art Fertility Center my best wishes. Thank you very much.
Thank you, Dr. Banka, for that presentation. So questions are welcome, those online and on-site. Questions on how we can improve our pregnancy rates. Questions? Do you want me to start calling names? Questions? Do you want me to start calling names? So I believe if we don't have questions yet, it's because we understand it perfectly well. Just wanted to ask, whilst others are thinking, in your experience, I want to find out why sometimes some patients don't end up with embryos. We actually had a 38-year-old a while back who had her AMH was about 2 point something, if I remember correctly, but she never had blastocysts. You know, each time on day 5, she will have about, or day 3 rather, cleavage stage, she will have about 3, 4, but by day 5, there will be no embryos. What can we do to help such a patient?
As you mentioned, she is a 38-year-old woman with a good AMH. What this tells us is that she will produce good number of oocytes because her ovarian reserve is good. but the quality is primarily dependent on her age. So even though she produces a good number of oocytes, the quality would not be as good as one would like it to be. And I'm assuming that the husband is normal, but the only possible reason here seems to be that she's 38, and it could be an issue of oocyte quality more than anything else.
Thank you. Another question is the type of FSH used for stimulation. Does that directly affect your pregnancy rates? Also, the type of trigger shot used. Does that, in your experience?
So by type of FSH, I mean you are looking at recombinant versus urinary FSH, if I'm not mistaken. Is that what you are trying to ask?
Yes, please.
Yeah. So the recombinant products are more consistent products. The urinary products are measured by bioassay, and hence there is a lot of batch to batch consistency. So if you look at the ovarian response over a period of time, with the recombinant products, you will have more consistent response over that entire period of time. With the urinary, you would have phases of hypo-response and hyper-response. That is the main issue with the urinary product, that the consistency would be not as good as one would expect or one would have with a recombinant product. For the trigger, whether it is the HCG or the agonist, it does not impact the quality of the oocytes or embryos in a majority of the patients, but you decide which trigger to give based on whether the patient is at risk of hyperstimulation, and are you going to do an all-freeze cycle, or are you going to do a fresh embryo transfer. So if it is a fresh, you give the HCG trigger. If it is an all-freeze, you give the agonist trigger.
Thank you, sir. We have another question here. It says, based on the question answered before, the question I asked about quality, that how can we improve on quality of eggs? How can we improve egg quality?
So, we cannot improve the quality of oocytes that a woman is likely to produce given her age and ovarian reserve, but we can prevent any further deterioration by following all the protocols, by not deviating from SOPs, and by doing things which are consistently good. In an IVF process, and more so in the lab, if there is a problem at any stage, it will lead to a deterioration in the quality, which cannot be compensated by doing something better later on. So the only thing that you can do is not do anything which will further deteriorate the quality. You cannot turn a poor quality egg or an embryo into a better quality egg. Maybe I think Professor Fatemi can add to this. This is a challenge, or this is something which everyone likes to do. How do we produce a better egg or a better embryo? Suman, would you like to add on to this?
No. Anybody?
You're on mute. Suman, you're on mute.
Okay. I think Mr. Dr. Wells, the first speaker, if you can unmute him.
Dr. Fatemi, you are on mute.
Okay. Thank you. In the absence of any other question, thank you so much, Dr. Banka, for that presentation. A round of applause, please.
Thank you. Thank you.
Okay. Thank you very much. So, I would also like to acknowledge the following: Dr. Deji Oluwole, who is the Deputy CMAC, and also the Chairman of the National Postgraduate College, Lagos, Nigeria. You're welcome, sir. I'll also like to welcome some of our friends and fellow AFRH members, Dr. Mishaki, consultants Luth, Dr. Ajayi, the Bridge Clinic, you're welcome. Dr. Ogunkile and Mrs. Dayo Yusuf, you are welcome. Origin. Online, I can see Dr. Olamijulo, the head of department, College of Medicine, University of Lagos. You're welcome, sir. Dr. Kunle Ajayi, Clearview Fertility Center, you're welcome. Dr. Otun, you're welcome, ma. Lagos State University Teaching Hospital. And to everybody online, I can't mention everybody, you are most welcome. Dr. Fibai, you're welcome, sir. So, next we want the representative of the Permanent Secretary, Lagos State Ministry of Health, in the person of Dr. Fumi Shokunbi, who is the Director of Medical Administration and Training Program, to please give us a brief talk. Madam?
Thank you very much. The MD, Alpha Assisted Reproductive Clinic, highly esteemed guests, distinguished ladies and gentlemen, I'm here to represent the Permanent Secretary, Lagos State Ministry of Health, Dr. Olusegun Ogboye. Dr. Olusegun Ogboye is not physically in attendance this morning because of an emergency state assignment. But I can assure you that he's here with us in the spirit because I was closely monitored to be here this morning. And that shows how important this event is to him. And I think how important Dr. Biru is to him. He has asked me to congratulate you, ma, and congratulate the entire staff of the Alpha Assisted Reproductive Clinic. And I want to say big, big, big congratulations to you. I want to congratulate you, congratulate every member and staff of the clinic. I want to congratulate all the partners seated, all the sponsors, all the doctors. I can hear one or two names of even my colleagues, my classmates, and many distinguished personality here, and everybody that has contributed one way or the other to the success story of this facility. I want to say a big congratulations. I thank God that today it's a reality. Thank you to Dr. Bero and the entire staff. Thank you for 10 years of quality healthcare services. Thank you for 10 years of professionalism. Thank you for 10 years of consistency. And thank you for putting smiles on the faces of couples. Thank you for touching lives. Thank you for contributing your quota to humanity, and thank you for all you do. And I think she deserves a round of applause for her and the Alpha Assisted Reproductive Clinic. And I think we can do better. It is worthy to mention that Dr. Bero is the first female fertility specialist to have a private clinic in Lagos State. She deserves a massive round of applause. We are proud of you. Thank you so much for all that you do. And we wish you nothing but the best in this coming decade. And we also hope that you will continue to maintain the standard. And this is also to tell all the other clinics to please continue to emulate what the alpha assisted reproductive clinic is doing. I have gone through the bronchial, and I know that today is really loaded, the topics and the caliber of speakers. And so I have no doubt that we're going to enjoy ourselves. It's going to be a very productive and a fruitful day. And on that note, I want to congratulate each and every one of us once again. Please enjoy the section, and long live Alpha Assisted Reproductive Clinic. Long live Lagos State Ministry of Health, and long live Nigeria. Thank you for your rapt attention.
Thank you, Dr. Shokunbi, for the congratulatory message. So we move on to the next speaker. Dr. Human Fatemi currently holds the position of Group Medical Director of ART Fertility Clinics in Abu Dhabi. He earned his MD degree at the Virgil University's Brussels, Belgium, in 1999. In 2008, he was recognized as a subspecialist in reproductive medicine and surgery by the ESHRE Group and the European Board and College of Obstetrics and Gynecology, and has successfully defended his PhD thesis on endocrinology of the luteal phase in stimulated and substituted cycles. Professor Fatemi is interested in many fields of gynecology, reproductive endocrinology, and surgery. As at September 2020, he had authored 140 international peer reviews and book chapters with a citation reports of over 2,400. Professor Fatemi has been awarded several grants, including a Pfizer Educational Grant as Best Graduate Fellow in Gynecology in Brussels, Belgium, and research grants from Merck and MSD. Ladies and gentlemen, let's give a warm welcome to Professor Fatemi. Thank you.
Thank you very much for the kind introduction. Unfortunately, when Dr. Banker was speaking, I could not unmute myself, so I hope you can hear me now. Prior starting, I would also like to thank Merck for having me, and of course, congratulate the Art Clinic for 10 years of sustainable, good quality medicine in Nigeria. And I really hope to be able to visit you at some point in person, live. The topic I'm going to speak about today is individualization in ART. As you know, it is not that one size fits all. We know that everyone is different, and the question is it possible to individualize the treatment that we do with patients? These are my disclosures for the current presentation. I have no conflict of interest. Now, if you take a look at the human fertility, we know that the number of the eggs of a woman declines significantly. In fact, a woman which is 24 weeks of age, she has around 7 million eggs. The moment she's born, she will be having around 1 to 2 million, but at that time, of course, she doesn't have any ovulation. So these eggs will wait until she will start ovulating, which is usually at the age of 12, 13 years. But then you go from 1 million to 300,000. And from the 300,000, from the first point where you start ovulating until you go to menopause, you would use around 4 to 500. And from these 4 to 500, more than half of them would be genetically abnormal. So as you can see, it's a very inefficient system, because you start with 7 million, you go to 1 million, then you go to 300,000. From the 300,000, most of them are genetically abnormal. Now, we define the patient's response according to variables. One of them is the age, the other one is the ovarian reserve. So at any given age, you might have a different number of eggs. So age is one predictor of response. The other one, the number of eggs, is another predictor of response. And if you ask me, is age the most important thing or ovarian reserve? Of course, the first answer would be age, but to me, the ovarian response is as important as age in the population we are treating. So you see, you can have a 25-year-old who is a high responder, you can have a 25-year-old who is a poor responder. You can have a 40-year-old who is a good or high responder, or a 40-year-old who is a bad responder. So age is one issue. The other factor is the ovarian reserve. Now, we always say in fertility, it's 50% man, 50% women. I would say I disagree with that. This is a beautiful paper which was published by Danny Sakas from Boston in the US, and I fully agree with that. At the end, if you take a look at the outcome of a pregnancy, 80% is egg. You know, egg plays a role, but the majority of the cases, the egg plays a major role. The old Romans were saying life comes from an egg, and I think that is the truth. Now, of course, we need to have hormones which are contributing to the stimulation of estradiol and follicular growth. Under FSH, cholesterol is converted to androgen and is brought intracellular. Estradiol is produced, part of it remains with the egg, and part of it is going to the systemic circulation. But what we need to know is that during the follicular recruitment, we have several phases of follicular growth. And the whole process takes at least 5 to 6 months. But basically, only during the last 2 weeks of follicular recruitment and stimulation, those follicles are responsive and dependent on gonadotropins. So basically, only the pre-antral and antral follicles are responsive to FSH, and once they grow further, they depend on FSH. But let's say 90% of the time, more than 5 months, those follicles are not responsive to FSH. I think this is an important factor. The other fact which is important, I think we always have to look to nature in order to understand how the follicle is growing. Now, in nature, what's happening, your FSH starts to grow in the late luteal phase, so not when you are in the follicular phase. In the late luteal phase, you have an increase of your FSH, and basically once the follicle has been recruited, you have a step down of FSH. So in fact, towards the end of the follicular phase, you have a step down. Now, this is exactly what we need to understand when we stimulate women. We need to understand that nature goes up and goes down. Of course, you might say, but nature goes with a monofollicular growth. You have only one egg growing. We are looking to multifollicular growth, but what if you could mimic the same, starting up, going down towards the end of the follicular phase? So in fact, this is what nature is doing, and this is what we are doing. And as you can see, they are antagonizing each other. Nature goes up and goes down. Here we go gradually up. And this makes a significant difference. Now, when we stimulate a patient, obviously we are using gonadotropins. We use FSH, we use sometimes LH, and sometimes the drugs contain ACG. And as you can see here, most of these hormones have a very similar structure. So if you take a look, for example, at LH, FSH, or ACG, they're very similar to each other. You see, they all have two compartments, alpha and beta. And as you can see, the alpha compartment between all these hormones is identical the same. They have 92 amino acids. The difference that you observe is in the beta chain. As you can see, this beta chain is making a difference on the activity mechanism of these hormones. Now, if you focus on FSH, FSH is a molecule, and as you can see, it has 4 arms, 1, 2, 3, 4. And each one of these arms, you can attach 1 sugar residues. And this sugar residue will contribute to the acidity of that molecule. It means if you have on the arm only 1 sugar, you have 2 sugar residues, you have 3 sugar residues, or you have 4 sugar residues. The higher the sugar residues you have, the higher is the isoelectric point, and the more acidic the molecule becomes. So if you have 1, 2, 3, or 4, and that can take times 4, it changes the acidity of the molecule. So if you take a look at the number of sugar residues, for example, LH has the lowest number of sugar residues. This is why the half-life time is very short, 20 minutes only, and it's broken down very rapidly. FSH is 3 to 4 hours. ACG, for example, has the highest number of sugar residues, as you can see, and this is exactly why the half-life time is so long. Now, also within the FSH itself, during different times of life, you have different isoforms. If you take a look, for example, in the 20s or 30s or 40s of a woman, or when she's in the menopause, or also before the man, you see that a difference in acidity. So postmenopausal women have a higher rate of acidity of FSH. And in fact, as you have seen, the longer and the more acidic the FSH is, the longer is the half-life time, and the longer will this FSH be active. So if you put it all together, recombinant FSH is relatively basic isoform. Urinary is more acidic. The highest acidity is basically corticoretropin alpha, which contains 27 amino acids, the so-called carboxy-terminal peptide, which gives the longest half-life of the molecule. Now, you might ask, how does it work in nature with the acidity? And it is not all or nothing. So it's always a combination of two different forms of acidity. And as you can see, in the beginning, you start with lower acidity, but towards the mid and end of follicular phase, you change the prevalence of acidity to a higher form of acidity. So basically, this is the way it would look like. Now, some people make mistakes when they compare a certain drug. Let's say they compare, I'm going to say something, recombinant FSH with HMG. And they draw conclusions, and they say the conclusion is this because we have this activity of LH or ACG or FSH. What we need to understand, even if you take out the fact of recombinant versus presence or absence of ACG or LH, it is important to realize even recombinant FSH compared to urinary FSH has significant differences without the presence of LH or ACG activity. So if you take a look here at the number and the estradiol, you see significant differences. Even if you would stratify in subgroups, you would see that different isoform of FSH is giving you a different endocrine profile. Why is that? It's simply because of the difference in acidity of that FSH. Now, another issue that we need to realize, and this is something I think we should respect more when we stimulate a patient, is the number of FSH receptors. You see, a follicle which is small, pre-antral or antral follicle, this follicle has the highest number of FSH receptors. But the bigger the follicle becomes, the lower is the number of FSH receptors. So in the beginning, you have a lot of FSH receptors. Once the follicle is becoming bigger, the number of FSH receptors goes down. And this graph describes it beautifully. If you take a look here, in the beginning, you have 90% FSH receptors. Once your follicle is only 10 to 12 millimeters, you have only 50% FSH receptors. And basically, towards the end of the follicular phase, when the follicles are 15, 16 millimeters, you barely have FSH receptors. You have more LH receptors. But why do you have LH receptors? These LH receptors are preparing the egg for the final maturation. Because the moment you administer your LH or ACG or agonist triggering for the final egg maturation, they will cover the LH receptors. And they are meant to create what we call nuclear and cytoplasmic maturation. So these LH receptors which are being created are purely meant for the final oocyte maturation. So a correct stimulation would, you start high because you have a lot of FSH receptors, but the moment you are going towards the end of the follicular phase, you need to reduce the pressure on the follicles. But what do we do in our stimulations? We start with stimulation But despite the fact that the follicles are growing, we continue stimulating the follicle, despite the fact that there are less and less FSH receptors. But we are accumulating our FSH with the stimulation. And this is a way a correct stimulation should look like, that you stimulate, and once the follicles have been recruited, they reach a size of 13, 14 millimeters to reduce the dose of FSH. So if you put it in a graph, they are again crossing each other. We do against nature, but we should try to learn and mimic from nature. The question is how much LH is required, not for the maturation of the egg, because therefore we are administering the ACG or agonist triggering. How much LH is required in a stimulated cycle? And as you can see, very low levels of LH are enough for the follicular growth, going from 0.5 to 1.2, 1.3, as you can see here. So the body requires just a little bit of LH to have a correct follicular development. The best entity, the best population to look how much LH is required are WHO type 1, the hypo patients. And as you can see, only 75 units of LH, recombinant LH, is required to have a perfect follicular recruitment. Now, if you take a look on the endocrine profile LH measurement, so if you measure the patients who have treated with in an antagonist protocol with REC-FSH only, and you would stratify those patients to low percentile, medium percentile, or high percentile of LH, you see very low LH values, the lower 25 percentile, medium or high, the pregnancy rates are exactly the same to patients who have extremely low LH values and to patients who have high LH values. And there is a beautiful meta-analysis published by George Griesinger from Lübeck in Germany, 1,700 patients. And as you can see, the overall, it's touching the unity line, the lower percentile, the higher percentile. There is absolutely no difference with the LH value. In fact, some studies have shown that these low LH values on the day of trigger have no impact. Even if you have high LH values, it might be linked to more miscarriages, and that low LH values are not predicting of an outcome. Stratis Kolovianakis, when he was working with me in Brussels, published many papers on this topic. Now, the next question is, how many eggs do you need to have a successful pregnancy? And I think this is a very simplistic question. Seksunkara published a huge database looking at 2-HFEA data, and she came with a number of almost 500,000 cycles that you need to have 15 eggs. But then my question would be 15 eggs with a 40-year-old patient or 15 eggs with a 20-year-old patient. The second question would be, how were these patients stimulated? Because the stimulation has obviously an impact on the quality of the eggs. And this is something which needs to be put in consideration. Another paper from Van der Gaast, same thing. You see 15 eggs, and from 15 onwards, it's going down. Why is it going down? Because we published a paper describing that more eggs means more pregnancy. So it's not the number of the eggs which is crucial. Maybe it is crucial to understand how you do your stimulation. Now, on the other side, how many eggs do you need? I think this number is linked to the age of the patient. 15 eggs with a 30-year-old will give you a chance of 80% of a singleton live birth, but 15 eggs with a 41-year-old will give you a 25% chance of a live birth. So these are factors that we need to put in consideration. Why does the number differs with different age categories? Very simple, because the older you get, the more chromosomally abnormal eggs you have. And what is the origin of this abnormality? Obviously, these are maternal abnormalities that are created with age. So one factor is how do you stimulate? The other factor is, does the stimulation have an impact on the endometrium and the receptivity of the uterus? We know that the uterus has something which is called the window of implantation. And this window of implantation, it needs to be respected, and it is controlled by steroids. And this we have thought that it was maybe 4 or 5 days, but today we know that the window of implantation is not 4 to 5 days. The window of implantation is possibly 2 to 2.5 days. But we physicians, we try to simplify things. What do? We do a ultrasound scan and say, okay, the thickness is good, so we are happy. But is it really the thickness, which is the only important issue we need to think? But maybe Also on microscopic level, things are happening. Maybe the endocrine profile, the hormones which are present in the systemic circulation, do have an impact on the receptivity of the uterus. We know the moment we start stimulating a woman, we create an abnormal endocrine environment. We know that all these parameters which are important for implantation differ significantly between a natural and stimulated cycle. In fact, Claire Bourgain, when she was working with us in Belgium, she published this beautiful study demonstrating all patients who are being stimulated have endometrial advancement. So every woman who is being stimulated, because you create multifollicular recruitment, the endometrium is advanced. And we just published a paper, it just was accepted last week. We demonstrated for the first time why the endometrium is advanced. Very simple, because the moment you trigger, within 2 hours, you have a progesterone rise. So all women have advanced endometrium. But if your endometrium is advanced more than 2 days, you simply have no pregnancies. So it is in our interest to keep the endometrium within the window of implantation. Another factor which is contributing to the endometrial advancement is obviously what we call premature progesterone rise. Now, rise of progesterone in the follicular phase is something completely physiologic. So we know that the bigger the follicle becomes, the more progesterone it produces. Progesterone is being produced, but this is mostly in the luteal phase. In the follicular phase, there is just a little bit of progesterone being produced just before the ovulation. But the bigger the follicle becomes, in the follicular phase, the more progesterone it's producing. And this is a beautiful paper from Schneiers published in GCM about 22 years ago. Now, we know that from a level of 0.9, the endometrium starts to become secretory. So you have a secretory transformation of the endometrium. So we need to keep the progesterone levels during the follicular phase below a certain level. Now, there are debates 1.5, 1.4, 1, or 0.9. It's difficult to say which is the best value, but for sure, if you want to be on the perfect side, you need to be below 1 nanogram per ml. And keep in mind that the bigger the follicle becomes, the more progesterone it's producing. And we published this paper looking into the gene expression. And as you can see, if progesterone is less than 0.9 or between 1 and 1.5 or more than 1.5, the higher the progesterone goes, the more changes you have in the gene expression. So we know that from 0.9 to 1 onwards, you start having changes on the endometrium. And these changes, of course, will contribute to the decrease of the pregnancy. So as you can see, you have a decline of pregnancy once you have an increase of your progesterone. And this happens in all patients. This happens in all age patients, in all quality blastocysts, and in different age categories. Now, the problem is, it seems also to have somehow an impact on the oocyte quality. Because if you have high progesterone during the follicular phase, it means something is going wrong with the stim. And this going wrong, it means somehow we are maybe stimulating incorrectly, that the progesterone is increasing. There are many papers out there also looking into the cumulative reduction of the live birth because of the high progesterone. Now, unfortunately, some studies came out, wrong studies, I would say, and I will tell you why wrong studies. This was the first which came out in 2006 in Human Reproduction. They said, look, the progesterone levels in HMG as compared to recombinant FSH are significantly higher with recombinant FSH. The only problem is, as you can see here, the triggering in the recombinant FSH group was significantly at the bigger size follicles. Now, the bigger the follicle becomes, the more progesterone is producing. Why? Because you have more LH receptors. And the same group did a study confirming that LH or ACG would prevent a premature progesterone rise. And as you can expect, the opposite came out. LH or ACG activity is not preventing a progesterone rise. It's promoting a progesterone rise. And as you can see, it's the same group, Tönnissen with Johan Smits. At that time, they published this paper in 2012 in Human Reproduction and basically confirmed that LH or ACG is not preventing a premature progesterone rise. It's actually contributing to a progesterone rise. And when you trigger on the same site, obviously, there is absolutely no difference in the prevalence of progesterone rise. And as you can see, there have been many other studies comparing, and there was no difference. But it's important to realize that LH or ACG is not preventing, as I told you, it's the opposite. LH receptors and LH itself is the primary cause of having a progesterone rise. You see, the LH values, the higher the LH value, the higher the progesterone value, and this is statistically significant. So one of the main reasons why progesterone is going up is not because of LH, is because of the way we stimulate with FSH. So this was the first paper we published with one of my PhD students, Dimitra Kirou, at that time, where we were looking what's the etiology, what's the cause of having high progesterone. It came out, it is somehow linked to the way we stimulate, it's somehow linked to the estradiol values, it's somehow linked to the FSH values and a number of follicles that we create. And we digged a little bit further, and Marco Filicori published also 20 years ago, where he described that FSH is creating LH receptors. The more LH receptors you have, the higher is your risk of having progesterone rise. So in fact, it was linked to the FSH that we administer. And imagine when you put too much pressure on those follicles, these enzymes, they have to convert from cholesterol at the end to estradiol. If you put too much pressure on these enzymes, at some point they cannot convert anymore. So what will happen, instead of producing estradiol, they will start producing progesterone. And this theory has been confirmed by Oktem from Turkey, where they absolutely confirmed the idea that too much FSH is the cause of a premature progesterone rise. Now, this is a paper published by Fauser, where they looked to the pattern of a step down or continue pushing up. And as you see, they are antagonistic, the theory. So what we did, we looked to the prevalence of progesterone rise if you haven't stepped down or if you continue with the same dose. And with my colleague Barbara Lawrence, we published this paper in Human Reproduction about 5-6 years ago. And as you can see, if you continue with the same dose, your progesterone goes up. But if you start high and you go down, you significantly reduce the premature progesterone rise. Basically, we had no patients who had premature progesterone rise, but what we did a step down. And we saw that this high progesterone is indeed directly linked to the FSH value that you administer. And this is a paper we just published about a year ago, where we started stimulating patients with GONAL-F, and we did the same dose until the end. Or what we did a step down, we started the same dose, but once the follicles reach a certain size, we started going gradually down with the stimulation. And it was very interesting to see. First of all, we confirmed the previous finding. The more FSH you give, the more progesterone you have. But more importantly, imagine you have the two patients with the same demographics. They have the same body mass index. They have the same ovarian reserve. You give the stimulation at the same time, and you measure after 1 week how much FSH is in the systemic circulation. The patients can have an FSH value of 7, which is very low, up to 25, 26, 27. As you can see, the lowest patient was 7, and the highest value was 27. This is a huge gap. Same dose. It means you might give the same dose of FSH to two patients with the same demographics, but the value will differ significantly. And I think this is an important message to be kept in mind when we stimulate patients. And obviously, the more FSH you administer, the more progesterone you create, and the lower will be the quality of your oocytes. This is a paper we just published, I think 3-4 months ago, where we describe basically it is time to start also measuring the FSH in the systemic circulation. Because even if you give 200, 250, or 300, we don't know how much of this FSH is active in the systemic circulation. The basal metabolism among women differs significantly. Maybe you give 250, but she has only an FSH of 9 or 10, which is very low. Maybe you give 250, but maybe she has an FSH of 27 or 28, which is very high. So I think when we speak about individualization, these are the points that we have to look at. Another paper we published a few years ago, also the length of stimulation seems to have an impact. If you're interested on these topics, we published many papers on that topic, how you can individualize the stimulation of the patients according to the data that you find. I think we can conclude that the moment we start stimulating a patient, we change completely the environment, endocrine environment, the endometrial environment. Progesterone is a very important hormone. It has an impact of endometrial preparation, but if there is a rise of progesterone, It has an impact on the misplacement of the window of implantation. And obviously, it has not directly an impact on egg quality, but indirectly, because high progesterone means you have created too many LH receptors, but too many LH receptors are not good for the final oocyte maturation. It has nothing to do to the type of analog that you have used or the FSH type. It has to do with the amount of FSH and the amount of systemically present FSH, which has an impact on egg quality. It is important, you can prevent a progesterone rise, and that is simply by following the nature. But starting at a higher dose, follicles have been recruited, but to the end of the follicular phase where you have less number of FSH receptors to reduce the pressure on those follicles, because if you give too much FSH, it would have impact on the quality. And actually IVF treatment, it's optimization and individualization according to the patient's response. If you are interested in that, this is a book we published actually March, April last year. We describe exactly the individualization on various aspects, follicular phase, triggering, and also the luteal phase. Thank you very much for your attention.
Quite informative. So questions are welcomed from the audience, online, on site. Don't let me call names. Questions welcomed. You have the yes. Questions?
Thank you, Dr. Fatemi, for such an informative talk. I just wanted to ask, once the progesterone rises, would it affect the outcome of the embryos? Because I hear sometimes that happens. So once it rises, and even when you don't transfer in that cycle, would subsequent cycles be affected?
That's a very good question. Thank you for that. In fact, there have been few publications out there. And as you would expect in science, you know, sometimes it goes to the right, sometimes it goes to the left. So we have contradictory publications among the quality of embryos. I can tell you, there is a publication by Huang, there is a publication by Vani, and there is a publication by Annalisa Racca. These publications demonstrated that it seems to also negatively impact the quality of the embryos and subsequent embryo transfers. It means the negative impact seems not only to be the endometrium, because even if you use subsequent embryos that you transfer, it seems also to reduce the subsequent pregnancies. So it seems also to impact somehow the quality of the eggs and the subsequent embryos that you have created. But what would be the rationale behind it? Most probably, you also have to distinguish. Let's say you have a progesterone of 1.5 and you have only 3 follicles. Or you have progesterone of 1.5, but you have 20 follicles. So these 1.5 coming from 20 follicles different than 1.5 coming from 3 follicles. So the amount of progesterone produced by each one of these follicles will differ significantly. So I think future studies need to stratify the possible negative impact, not on the total value, but on the value based on the number of eggs and embryos available. So most probably, if you have a certain value, but you have many eggs, the negative impact will be very limited. But if you have 1.5 or 2, but you have less number of eggs, most probably the impact would be much more severe.
Thank you.
Okay, thank you. So another question. I want to find out if this issue of progesterone is commoner with antagonists as opposed to the long protocol. Because with long protocol, initially we downregulate. So I want to find out whether it's commoner. Then also, I want to find out with the antagonist protocol, the value of the LH or the normal range you think the LH and estradiol should be when you're starting stimulation. Apart from progesterone, we know that if progesterone is high, but what of the LH, the significance of having very low LH levels, and what is considered low, and the significance of having very low estradiol levels at the commencement of stimulation? Thank you.
Yeah, thank you for two questions. So first of all, there is no difference between agonists and antagonists because the cause of progesterone rise, it is, as you have seen, based on the amount of FSH we administer. So with agonists or antagonists, the only difference is with the agonists, you synchronize the follicles more and you downregulate, with the antagonists, you don't. So the prevalence is the same, but the cause, the etiology of having this premature progesterone rise is linked to the amount of FSH you administer. So it's not linked to the agonist or antagonist, it's purely the FSH you administer. Now, regarding the LH value, I had a slide where I had put all the values in there. The lowest LH that was described to be sufficient in a long agonist protocol was 0.5 international units. And the value was between 0.5 to 1.35. So basically, you just need a little bit of LH, just a little bit of LH to have a correct follicular recruitment. The only thing is sometimes you see you are stimulating women and you see the estradiol levels are not rising very well. The estradiol rises very slowly and the follicles are not growing well. If you see there is a mismatch between the steroidogenesis, the amount of estradiol produced per follicle, that is a patient who might be requiring a bit more of LH activity. But if you ask me what percentage of patient would that be, I would say less than 10% of the population who would require an additional LH activity during the follicular phase. Most patients will have enough with an LH between 0.5 to 1.5, which is present in a normal systemic circulation.
Thank you very much, Prof. Any more questions?
So when there is a rise in progesterone, is it advisable to cancel the treatment cycle? Because it is said to affect the embryos.
First of all, it depends on the total value of progesterone. So imagine your progesterone is 1.4, 1.5, but you have a lot of follicles. You have 15, 20 follicles. There, I would go ahead, but I would freeze the embryos and I would put it back in a subsequent cycle. There, I don't think there is a negative impact on the egg quality or embryo quality. But imagine you have a patient, she has 4 or 5 follicles or 3 follicles, let's say a minimum responder or a poor responder, and you have a progesterone of 1.5, I think the negative impact is huge with that patient. So maybe in that patient, it would be better to discuss with her and cancel the cycle and start again and do a proper step down in order to prevent this to happen.
Thank you.
Thank you very much. Any more questions? Right. In the absence of that, thank you. Okay. Thank you so much, Professor Fatebi, for that excellent presentation. Please, a round of applause.
Thank you for having me.
All right. We want to just cut the cake now. Okay. I thought we still have time. Okay. All right. So we'll go straight to the next item. We'll be talking about ART in Nigeria, the past, present, and the future. And the person giving this talk is the founder of NISA Premier Medical Group. He obtained his MBBS degree from Ahmadu Bello University, Zaria in 1980. He held residency posts at Jos University Teaching Hospital, Cambridge, UK, and Queen Elizabeth Hospital, Kings Lynn, He was a clinical research fellow in reproductive medicine in Manchester Fertility Services between the periods of 1989 and 1990 and St. Mary's Hospital, Manchester. He's a fellow of the Royal College of Obstetrics and Gynecology, UK, fellow of the West African College of Surgeons, and has held consultant posts in Bourne Hall Clinic, Cambridge, Gwagwalada Specialist Hospital, and a chief consultant at the National Hospital, Abuja. He was chairman, Medical Advisory Committee at the National Hospital from 2002 to 2004. He became the medical director of Garki Hospital, Abuja from 2007 to 2009. In addition to his medical qualifications, Dr. Wada holds a Master's of Business Administration in International Hospitals and Health Management from the Frankfurt School of Finance and Management in Germany. Dr. Wada is a recipient of the National Award of the Officer of the Order of Niger, conferred on him by the federal government of Nigeria in 2006 for his groundbreaking works in the field of in vitro fertilization. He has authored in more than 15 academic peer-reviewed journals and has published 2 books, The Second Chance and PPP in Health. He's also the current president of the AFRH. Ladies and gentlemen, let us welcome our very own Dr. Ibrahim Wada. You're welcome, sir.
Thank you very much. Good morning to you all, especially happy 10th anniversary to Dr. Bero and her team at the ARC Clinic. We are very happy that you're a member of the AFRH family, and we wish you a much brighter future than ever possible. God bless you all. It's my pleasure this morning to talk about the ART in Nigeria, past, present, and future. I'm not the one sharing my slides, so I will make a signal of next slide, and they will please help me to go to the next slide. But it's a great day for our country, and I'm pleased to give a 10-15-minute talk on this topic. Next slide, please. Anyone addressing the past, the present, and the future of ART in Nigeria or anywhere in the world for that matter must trace the origins of the science, where it is now and where it's heading for, ethical considerations of application of those origins, the current practice, questions about outcome, how practices are regulated historically, and what lies ahead for us. And the big question of research. It all started with some research. Where is that research leading us, present and the future? Next slide. Now, the evolution of ART science is almost like a love story, because man was playing where no man has been before. Let's put it that way. How can you allow fertilization outside the body? How can you even put the embryos back and even get implantation? Some wise people, abstract people, must have led this kind of thinking right from the beginning, the middle of the 19th century. Work in animals led to gradual confidence that such work can be translated to human beings. And I think the groundbreaking work for the world is by Steptoe and Edwards in 1978 with the birth of Louis Brown. But the underbelly of the research that Edwards did and the laparoscopy contribution of Steptoe started way back before then, maybe 10 years before then. Back home, we have our own beloved Professors Ashiru and Osato Giwa Osage, who way back in the early days of IVF had traveled abroad and brought the science to Nigeria. And then, of course, the development of freezing embryos in animals, which eventually then came up to human beings, to put an injection into the cytoplasm and then later into the nuclear matter of embryo cells. All that in the early 90s. Embryo biopsy also to be able to determine the genetic composition, etc. So you will see after the colored program is the white program, which says stem cells, gene editing. These are elements of present and the future. And I think I will address it more as we go into further depth of research and science. Then we look at this thing, this slide. It's all about achieving what the original plan is. An infertile couple, millions of them around the world, they want to have a child. How successful? And I was very interested with the definition of success and the measurement of success, but that's beyond the scope of my presentation this morning. What are the challenges on the way? Let me remind you that once upon a time, especially in the 80s and 90s, ovarian hyperstimulation syndrome was on the lip of every practitioner in IVF. Even here in Nigeria, so was it. But today, the evolution of work, the purification of medications and all that is allowing us to say, my hospital is OHSS free, ovarian hyperstimulation free. And I think that can be almost taken almost for granted in many of our practices. Where is this going to lead us? I suspect it's going to lead us to where Louis Brown started. That's the natural cycle. As perfection of ovarian stimulation agents with recombinant work, as understanding of what allows the selection of the dominant follicle that should have the egg that bears life, and managing it increases. Success rates in the beginning, if Step 2 and Edward had 5 out of 100 or 10 out of 100, they would be jumping. You remember that there was a lot of work before Louis Brown was born, and thereafter there was silo for a while before multifollicular development. And now what many people are saying, if you have an IVF center that cannot return 50% implantation rate, there's something wrong, and you can look into your patient selection or modus operandi. The other challenge historically is that of multiple births. It was a cause of illness, it was a cause of death, it was a worsening thing for ovarian hyperstimulation syndrome. We all know that the world is heading towards single embryo transfer, which is established in many climes. But it is hopeful that as our technology and science develop in this country, we will follow. Of course, there are clear indications for SET, single embryo transfer, in our practices, but we are hoping that it will become a general practice. A lot of injuries at the very beginning, especially when it was laparoscopic work, but now with ultrasound work, it's getting much, much safer. Here again is the need to biopsy an embryo before you determine its genetic components and the loss of embryo lives attendant to this attack. Not all biopsied embryos survive. We all know that. So the development of biomarkers to overcome the challenge of losing embryo life unnecessarily, especially if you're doing it in the cleavage stage rather than the blastocyst stage, all these are points of consideration of what the future holds. So biomarkers that can tell you the quality of embryos, and you can even determine implantation potential of such embryos from that point. I turn my attention to the ethical questions, and they will never end. There is nothing other than arriving at nature eventually that will stop us from asking many questions. We don't know, even though there are millions, 8 million or so babies born outside the body fertilization in vitro, we don't know enough, because Louise Brown is 40-something now, and people live to be 80. What's going to happen to her and to the other babies as they cross midlife is a big question yet unknown. Organ survival, and many, don't know what their own lifespan can be like eventually. So man-made fertilization is still an ethical question, and it will continue to be for some time. Third-party participation in ART, whether it's sperm, eggs, or uterus, is also a debate in most parts of the world, and that's the precursor to a lot of tough regulations to control the application of this new technology. There are also many research issues towards optimizing for the parents, prospective parents, for the embryo, and for the practitioner, the methods of assisted reproduction to make it as stress-free, as affordable, if you like, as accessible as possible. These are ethical considerations in any country because you can't have a science that is so expensive and is to the exclusive preserve of certain groups of people in any society. So these challenges are there. Ethics controlling human research are also important. How long can you work on a human embryo in culture? This leads us to the next slide, please, about the issue of regulation. Originally, when Steptoe and Edwards were doing their work, and I'm sure even when Ashiro and Osagi were doing their work, there wasn't a lot of law because it was dark ages then. Remember that HFEA was the first organ to address fertilization outside the body, the rules and regulations, and it's embodied in UK law. Since then, almost all the countries that are doing ART have done some kind of modification or the other of the HFA law. In Nigeria, the AFRH had to do a self-regulation of these practices as best as we could because to get it into law will take a long time. But I can almost share with you the good news that the MDCN, the Nigerian Medical and Dental Council, has taken up the challenge, and I hope that at least by the end of this year, some of the recommendations of a committee that they set up will be taken up in the ART, in the MDCN control. So we have opportunities to make sure that the environment where the ART is practiced is sweet and regular. Personnel that do it are qualified, because we are also in a place where there's a spring up of hospitals and clinics all saying they're doing ART without the opportunity of proper training, and our society is paying a heavy price for that. Number of embryos to transfer, what do you do with excess embryos? Must freezing or relationship with the freezing center so that we don't waste embryos be a core practice for centers that don't have opportunities for freezing. If we go to the next slide now, please. Next slide. So research has continued to show where we have fought. If you add on to ART, I remember the ends of when we have to sound the uterus, when we had to add all sorts of supplements, when we had to use even the contraceptive pill to prepare the lady and nutritional changes 3 months before embarking on IVF. Time has shown and research has shown that there's little benefit from a lot of the add-ons. And I think this is an ongoing debate that we must look for some elements that will help. I don't think there's anyone, whether it's DHEA or otherwise, there's none that we can sign on as proven. The research on the endometrium and on implantation and the communication between the embryo and the developing endometrium. Of course, everybody knows about the implantation window, but we need to know much more about that. The embryo that will have more than a 90% chance of implantation, and the endometrium that has more than a 90% chance of receiving that embryo, they will be the goals of current and future research. The oocyte, and whose oocyte are we talking about? With stem cell at our door that can become sperm or become an embryo. So a woman who is not capable at any time will be able to find some, conversion. And I think this is happening in animals. I hope it will not be too long before people who are having to have donated oocytes will start smiling that, maybe from my saliva or maybe from my cells, you can make my oocyte or my sperm, for that matter. Also, the oocyte that you can almost bet on to be a good embryo, whether using biomarkers or the continuous monitoring. I can't remember the name of the system now, but you can detect rate of division and all that, and be able to pick out the best of the embryos that will implant. Genome editing or surgery to correct embryos to tune it to what you want. It's research, it's happening, but I think it will be a bedrock of modern ART in the future. And I dare talk about mitochondrial donation, the powerhouse for where there are mitochondrial defects resulting in unpowered embryos. And that donation is the so-called three-parent embryo that I believe many of us are aware of. Again, where such defects exist, I believe it will be common practice in this country and the rest of the world. What about cloning? Isn't that a simple way to go without all of this? I believe, too, that what stops us from cloning today, just like it stopped us at the very beginning of intervention called ART, that again will give way. And if I can make a second Dr. Wada, why bother? If I can make one Dr. Beru, why bother? It will make sense of, continuation of existing genomes and new genomes being created. And if we can take our attention to this now, so what am I saying? We are aware of the past and the present, but what does the future hold? And that's the exclamation mark. I think that we will go back to the natural cycle, manipulated to perfect the egg. I think that if that's going to be difficult, we're going to use stem cells from the person who wants to have eggs or the man who wants to have the best sperm potentials. I think that we will be able to have at least a 90% prediction of life from the laboratory before it goes into uterus, artificial placenta. These are questions of the future that I think we will do. I think the people who want to do IVF or family planning in the future, they're not going to suffer the way we are suffering now, just like the people of the time of Louis Brown suffered. Hundreds of them with very little results. The future is saying the people can always be certain, to arrive at their destination after all the research and effort that our generation and the coming generation will put. I want to use this to appreciate posthumously Steptoe and Edward that led this to wild science that has become everywhere science. I want to also appreciate our own home specialists, Professor Ashiru, Professor Giwa Otage, without whom many of us here will not be doing ART. And thank you all. ARC Klinic, congratulations on your 10th birthday. The ARH community are with you, and we hope that the next 10 years will beat your imagination. Thank you very much for listening to me. Bye. Did anybody hear me at all?
Yes, sir. Well, thank you so much, sir, for that stimulatory talk on the past, present, and future of ART. So if you have questions for Dr. Wada, he has really stimulated us, but I'm not sure the pharmaceuticals would agree with you, sir, concerning the natural cycle, because that means we will not be stimulating, and I don't think Merck and Ferring will agree with that.
No, I think I better clear the air. I think their products, now that they have recombinant technology, in the selection process for the eggs, they're going to find chemicals which eggs in the woman are going to be dominant. With developing in vitro science, you don't need 20 eggs or 10 eggs for that matter. So I am sure their chemicals will be tuned to perfecting a few rather than selecting from the many. So they will still be relevant. Okay. And that means many millions more of people will be able to access the science.
Excellent.
Thank you.
Thank you, sir. Any questions?
I'll just ask a question. In this situation where there's no regulatory body per se, I mean, we don't really have regulations pertaining to IVF. If we wanted to start things like mitochondrial transfers, who do we ask? Do we just go ahead or?
I think that the AFRH recently also talked about setting up a functional ethical committee. We have an ethics committee, but their work was to set ethical guidelines. Now we are trying to set up a body whom people like you can submit to, and we scratch our heads and say, this makes sense now. It's safe, you can go ahead. Until such a time as we are blessed with a Nigerian HFEA or other regulatory body. But AFRH is the group to look up to right now because they're about to set up a big ethical committee.
Thank you, sir. Any more questions? Okay, in the absence of that, we've heard from the current AFRH president. Now we want to hear from Dr. Faye Ketubosu, who is the past president of AFRH. You're welcome, sir.
Thank you.
Good morning, everyone. Permit me to stand on existing protocols. It is an honor and a privilege to be here today. When I received the invitation, I immediately put it in my diary as a must attend. And not so much for the wonderful symposium that was outlined, but more particularly for Dr. Biro, whom I have watched grow over the years. I've known Dr. Biro for many years as a young doctor, and I've seen her blossom. And I'm extremely proud to be here to witness 10 years of her work. As we celebrate you, I wish you many more years. I know your patients speak glowingly of you. Your center has made waves in a very short time. 10 years is a short time when you compare to the length of time we've been doing ART in Nigeria. But you've made an incredible impact, and indeed we're very proud. We're also very proud of you as a member of AFRH. AFRH is an association that encourages standards, encourages perfection, and encourages excellence. And we're thus very, very happy and proud to have Dr. Biro blazing the trail, not just as a practitioner, but as I mentioned earlier, as the first woman to actually blaze the trail with an IVF unit. So on behalf of myself, I congratulate you heartily and wish you many more years. I know that the future has just begun. Congratulations.
Thank you, sir. Thank you, sir, for that message. Next, we'd like to call on Dr. Oluwole, who's the chairman of National Postgraduate Medical College and the deputy CMAC of Luth, to give his congratulatory message.
All right, good morning, everyone. Let me stand on existing protocol. Let me give my senior colleague, Dr. Faye. I call him Egbon. He's always an Egbon anytime. Even though we're trying to chase him down with the white hair, but an Egbon is an Egbon all the time. I want to thank everybody. I want to thank ARC. Dr. Biro, she knows that the moment I saw the invite, was Bimpe that gave it and said to me first. She now said, I said, why are you sending it to me? The moment people sent it to me, I knew I was going to come. She's my sister, and I must say that everything everybody has said, it's true concerning you. And I can only wish you greater heights. Luckily, as fate will have it now, I'm the current chairman of the Faculty of ONG, National Postgraduate College. And the National College has approved specialization in ONG, which has been long overdue for the National Postgraduate College in reproductive medicine. And we have a policy now that we're going to partner, because we all know government alone can't do it. Most of the facilities we have in government hospitals are not adequate. So we're going to partner with private enterprises. And I'm sure HAC will be top on the list also. There's no doubt about that, because you are an epitome of excellence and steadfastness. So again, on behalf of myself, National College, and Luth, where I happen to also work, I want to thank you and congratulate HAC and all the staff. Thank you very much.
Thank you, sir, for that brief message. Next, we'll be cutting the cake. But before we do that, I would like to also acknowledge our dear Dr. Pandi. Where is he? And his team. Thank you very much for your support. Ignat's Pharma Nigeria. I see behind Dr. Ijoma Iwala, the MD of Havana Specialist Hospital. You're welcome. Already for the next session, I acknowledge our speakers. Mrs. Biola Adewusi is already here. Mrs. Yemi Popola, I think I see her. You're welcome. So everybody sit tight, still loaded. But now we'll cut the cake. And to help us to support Dr. Bero would be, of course, Dr. Tietu Bosun, Biola Adewusi, Dr. Oluwole, Dr. Shokumbi, please. And please, sorry, the ushers, can you get everything ready whilst they come? There's a knife there. Okay. So please, Dr. Beru, Dr. Iketu Bosu, Dr. Oluwole, Mrs. Adewusi, and Dr. Shokumbi. So, before we cut the cake, we're going to spell the ARC. So, give me an A, an R, and K. We have ARC. Congratulations. Happy birthday to us. Thank you very much. Thank you very much. Please, ma'am, still, but thank you very much. Thank you. Then we just want to call on our dear friends and sponsors, Ferrin, Merck, just a representative to take pictures with you. Mr. Pandi, Mr. Peter, Alpha Pharmacy. Thank you. Where's Mrs. Agu? Cheers Diagnostic. So we will be recording the cake after spelling 10. Give me a T, an E, an N, 10 years. Thank you all. Thank you all. Thank you. Okay. And finally, we want to call on our colleagues, fertility specialists, gynecologists, please come Dr. Ajayi, Dr. Omishaki, Dr. Obodo, Dr. Wala, Dr. Odega. Please come, please come, please come. Dr. Ogunkile, sir. Dr. Uche. How can I forget you? Our first guest that arrived prompt. Thank you all for coming out of your busy schedule. Thank you. So we love every other person. We're still going to take pictures with you. All right. So, but we need to go on our coffee break because we've spent some time here. We know you need light refreshments, and we'll come back for the next session very soon. So, coffee is right behind us. Let's just quickly go for our coffee break. Thank you very much. Thank you for your audience.
Previous.
IVF. This traditional surrogacy is also called partial surrogacy or natural or straight surrogacy, which is what people used to do in the past. Now we have the gestational surrogacy, where the embryos generated are via IVF and is transferred into the womb of the surrogate. The pregnancy results from the transfer of an embryo generated by IVF, like I said. So the embryo is in no way genetically related to the surrogate. And that's the one that's the only one we practice at the ARC. So there's also there may be monetary compensation, or that may or may not be involved with monetary compensation. When it involves monetary compensation, it is called commercial surrogacy. And it is when money is received for the agreement. I'll just talk a bit about the history of surrogacy. I'll quote a bit of the Bible. In Genesis 16:2, Sarah said, "For those that know, please go into my handmaid, that it may be that I obtain children by her." So also Genesis 33 says, Rachel said, "Behold, my maid Bilhah, go into her, and she may bear a child by my knees, and I also may obtain the children by her." So surrogacy goes a long way back. In 1976, lawyer Noel King, who is sometimes called the father of surrogate parenting, brokered the first legal agreement between a set of intended parents and a traditional surrogate mother. Then in 1980, There was a first paid traditional surrogacy agreement, whilst in 1985, there was the first gestational surrogate pregnancy. The first gestational surrogate pregnancy took place. So how does surrogacy work? It varies from country to country. It is legal in some countries, whilst it's illegal in others. Sometimes it even varies from state to state, even within the same country. Like in America, it varies from state to state. In some countries, surrogacy is allowed and is simply for altruistic reasons. And commercial surrogacy is not allowed. But in our own environment, it is mainly for commercial reasons. In Nigeria, there are no laws presently governing surrogacy. So the practice varies essentially from one fertility center to another. But a few years ago, Lagos State released some guidelines as to how to practice surrogacy in Nigeria. Sourcing for a surrogate. I'll leave Ms. Abiola Adewusi to talk about that in more detail, but essentially a surrogate could be a friend, could be a family member, or such as a sister, cousin. Even mothers have been said to be surrogate carriers for their daughters. And of course, there's the surrogacy agency. Regardless of the source, the potential surrogates must fulfill the criteria. And for us as a clinic and as per the guidelines Lagos State set, the surrogate has to be older than 21. I think 40 is the upper limit. And also, there's 40 or 44, I'm not sure, that Lagos State gave. And they ought to have had a child, at least one child before, and not more than 4 children before they come and do surrogacy. And of course, there's the legal aspect which Ms. Akinrele will speak about. So what's the ARC experience? I'll just talk about the ARC experience the past 5 years, though we started surrogacy from inception 10 years ago, but our records, we were able to get better records within the last 5 years. So number of surrogacy cycles done between January 2017 and December 2022 have been 178 cycles. Number of positive pregnancy tests, 73, which gives us a 41% pregnancy rate. Live births in the years reviewed were 43. Ongoing pregnancy, 10. And we've had some early pregnancy losses and miscarriages, 19. And we had an intrauterine fetal demise of 1 at 28 weeks. But luckily with that, the lady used 2 surrogates. So luckily her second surrogate carried the second baby to term and she's since delivered. So what are the indications for surrogacy at the ARC? The most common indication is repeated implantation failure. When we've done so many IVFs and we're not getting results, or they've done it before they presented, we usually advise that they do, even if they want to try again, we advise they use a surrogate backup. And what we found in a number of times is that most of them would get pregnant as compared to their previous history. So uterine factors, fluid in the endometrium, I'm sure a lot of my colleagues can attest to this, that can be a big challenge. Or thin endometrium, the endometrium not thickening, intrauterine adhesions, as we see in Asherman's, and multiple fibroids. Also, recurrent miscarriages. Some have had hysterectomies from previous, and if they've had greater than 3 previous cesarean sections, we would advise them to use a surrogate. However, we bent this last time. There's a lady who was very desperate to have a male child, and she had had how many? 4 cesarean sections, but we made her sign a consent, and she since delivered. Thank God she was able to get her male child. So advanced maternal age, we advised her to do surrogacy, which she declined. Advanced maternal age and coexisting medical conditions, like I had said before, there's a lady, there are about 2 people that have heart diseases. One has a history of deep vein thrombosis, kidney issues, and severe endometriosis have been the indications at the ARC. We have a patient that had a history of endometrial carcinoma stage 1, so we decided to use a surrogate. Also, a patient with the androgen, we've had 2 patients with androgen insensitivity syndrome that we've had no choice but to use a surrogate. What are the concerns about surrogacy? The ethical issues. Questions arise as to, there are a few questions ethical questions that have arisen. Is it an exploitation, especially if the surrogate is less privileged? Maybe, maybe not. In our environment is one thing to consider because a lot of people are desperate and they see it as a way out. There's also the question of the baby. What are the rights of the child born through surrogacy? Does that child have a right? And also the woman, the woman that has given herself up for surrogacy. Is a woman allowed to make contracts regarding the use of her body, regardless of the society, and to what extent? Is a woman allowed to do what she wants? So those are the questions that arise. And in conclusion, we know there's still some controversy about using a surrogate mother to have children, especially in our environment, where some may have very strong cultural and religious views. What I've found is that when you are not in a situation, you sit down, a lot of people can be so judgmental in our environment. They sit down and say all sorts of things. However, we should remember that surrogacy is one of the ART treatment options, and it has made the dreams of parenthood come true for many couples. And like Dr. Wada was saying, they are now beginning to consider the use of artificial uteruses. They have succeeded with a goat to term, and they are considering trying it on humans, but I think that would take a while, in which case we would no longer need surrogates. But let's see what evolves in the next 10, 20 years. So thank you for listening.
Thank you very much, Dr. Adeyemi Bello. Fantastic introduction. So now that we have a little bit of the history of surrogacy, I think that it would be good for us to move on to the next presenter. And I'm rolling the drum. Who do I want to call? All right, let me call Dr. Ogunro. I know she's looking at me like, yes, you're next. Be careful. I know you've been working hard all day, but...
Right. Welcome, everyone, to the second segment. And I want to thank the MD for the opportunity to talk about this not so interesting topic, which is recurrent implantation failure. When do we stop? Because recurrent implantation failure is devastating both to the doctor and the patient. So by way of introduction, we know that over the past 4 decades, IVF has helped millions of couples to achieve their desire to become parents. However, we know that despite the fact that things have improved, as Dr. Wada said when he took us through the history of IVF in terms of the process and other things that are being done, IVF is actually more likely to fail than to succeed. That's the truth. So the first cycle a patient has, there is a 25 to 30% chance that she gets pregnant, meaning 100 people do it, 25 to 30 will get pregnant. What happens to the 65 to 70 others that do not achieve the pregnancy? It's quite devastating. But when we now talk, and we know also that the more you do the treatment, the higher the cumulative pregnancy rate increases. So after 3 IVF cycles, pregnancy rate increases to about 45 to 53%. And after about 6 IVF cycles, embryo transfers, it increases to about 65.3%. But still, after 6, it's just 65.3%. Not encouraging. So we still have another chunk, about 35%, still believing after 6 embryo transfers. So what is recurrent implantation failure? To show how troublesome this is, the experts have not been able to agree on the definition. There are so many things people consider when you say a patient has recurrent implantation failure, but we want to keep it simple because in the first session, Dr. Rand already gave us all the definitions. So just to make it very simple, because we know we have non-medical people here, is when you've had 3 embryo transfers and you have not achieved a pregnancy. That means failure to get pregnant after 3 embryo transfers with good quality embryos. There are other definitions that talk about the number of embryos. There are other definitions that include the age of the patient, but I want to keep it simple. And like I rightly said, it is very frustrating and traumatizing to the patients and to the doctor. For everybody practicing IVF, it is very hard to face a patient after weeks of injections, after sometimes patient tells you there are financial challenges, to face them and tell them it doesn't work. It is even harder when a patient tells you, doctor, why didn't it work? And you cannot give the patient an answer. So it's quite frustrating to both the clinician and the patient. So its treatment constitutes one of the most challenging fields challenges in the field of IVF. And there are different causes of recurrent implantation failure: wrong lifestyle, smoking, obesity. The link between recurrent implantation and obesity, they've linked it to that sometimes with all the imbalances you have when people are overweight, that sometimes this affects the receptivity of the endometrium. It affects how the endometrium welcomes the embryos. Also, because people that are obese also have some metabolic disorders that can also affect implantation. Then with smoking, we know that this causes impairment of the endometrial maturation and also disturbs the invasion of the embryos into the womb. Also, other causes are low quality gametes, okay? If, for instance, quality of eggs is an issue, if the woman keeps trying and doesn't try other options, probably for personal or religious reasons, this can also affect. Also, uterine factors, as mentioned earlier, you may have polyps, you may have fibroids within the cavity, you may have adhesions, that's sticking together of parts of the womb as a result of previous surgeries, or people that are born with congenital abnormalities of the womb. This can cause, if these abnormalities are not corrected, it can also lead to having repeated implantation failure. Autoimmune conditions. Basically, autoimmune just means usually you have soldiers in the body, and then you see your body just keeps fighting the fetus instead of accepting the fetus. So there are certain conditions like people with lupus, okay? People with antiphospholipid syndrome, to mention a few. Thyroid disorders as well, they may have associated antibodies. And these antibodies keep attacking the fetus, and this causes repeated failures. But to a great majority, the truth of the matter is that we do not know. So, occasionally, yes, we are able to identify, but a large majority, we do not know. And that's because the implantation stage is very crucial, yet poorly understood by clinicians. We know, next slide please. We know that there are certain steps that occur before implantation can take place. Apposition, adhesion. For eventual step is that the embryos invade the womb, the cavity of the womb. But we know that for that to happen, you need very good quality embryos. The womb should be receptive at a particular time. In the last session, we are now told that we actually thought it was for a particular time, but now we are told that it's actually shorter. And also, we know that there is this love language between the embryos and the womb. They actually signal. There are certain signals that at the end of the day, when accepted, implantation takes place. So the truth of the matter, until we fully understand this process of implantation, we may not be able to fully treat recurrent implantation failure. So because of the pressure that recurrent implantation actually mounts on the clinician, it has led to what we call adjuvant treatments or therapies. Okay, people are trying to answer the question, why isn't it working? And it has led to a lot of other treatments that we add because, well, research shows that it helps. Okay, and like the this first speaker told us that, you know, there are times when they come and say, this one, Cochrane review says, because in medicine we have what we call evidence-based. They take a lot of all the researches, we look at all the papers and be able to conclude whether the research, whether we have strong evidence to use this particular treatment. For most of the things I've listed, we don't have strong evidences and it's quite controversial. Some people will say, yes, it works. Some people will say it doesn't. We know about endometrial scratching because they say it stimulates certain chemicals that help certain hormones that favor implantation to be produced. Also, we also know that endometrial scratch, those people that did the research said that it also helps to delay the endometrial maturation. We've talked about, there are other treatments like using HCG, putting it into the womb, because we know that at some point during the signaling, the embryo also, HCG is produced that helps the embryo actually attach. So people have said, okay, if this happens, we notice that these things happen naturally, why don't we try putting HCG inside? Then we also have what we call GCSF, which is the granulocyte corneally stimulating factor. Either you do it, put it in intrauterine or subcutaneously, but actually for the GCSF, there is a very, very strong evidence that it actually helps those people with recurrent implantation failure, especially the subcutaneous one. People have said for some people it's because they have this chronic inflammation, okay, chronic endometritis, and that's what some patients are placed on prolonged use of antibiotics to see whether it will help prior to the time they start stimulation. We also have, because of these autoimmune things, these soldiers that just overwork or overreact. We have introduced things like intralipids and intravenous immunoglobulins that help to reduce the level of natural killer cells. We also, for those people that have antiphospholipid syndrome, the use of aspirin, low molecular weight heparin, and prednisolone has also helped. So we have, the list is endless. I mean, there are so many things that people do just to improve on the pregnancy rates. So what is the effect of these subjects? Because it's going to stimulate a discussion. To the clinician, it puts the clinician under a lot of pressure. You know, your patient sits down in front of you and you're telling the patient it didn't work. And the patient is telling you, doctor, why didn't it work? It encourages the patient better when you have a reason. But when you're like, look, the embryos looked very good, your endometrial lining looked good, to the best of my knowledge, then the transfer went very well, and it didn't work. The patient is almost like, maybe you don't know what you are doing, maybe I should try something else. And you know, as doctors, you just feel like maybe there's something, and you start interested. So it puts the doctor under a lot of pressure, and it can also be very embarrassing because, you know, first one did not work, second one did not work, third one, and you start introducing things and you tell the patient, don't worry, everything looks good. We want to use this one, I want you to use this, especially when they are very pricey and they use everything you ask them to use, and yet another story. It can be very embarrassing to the doctor as well. To the patient, quite devastating, very, very devastating. It can strain relationship between the couple. Financial burden, IVF doesn't come cheap. It is not cheap. So having repeated failures is actually very, very frustrating. There are other things to use money for, and then keep doing this, and it can be frustrating. And also the emotional burden, okay, the uncertainty, the fact that, okay, if you want me to do another cycle, what is the guarantee that I will succeed? Nobody can give that. So it's actually a burden to both the patient and the clinician. So when do we stop? It's like scientists, we have to ask ourselves, is it worth it to continue to try, to keep trying? I earlier mentioned that the more we try, the more we increase our cumulative pregnancy rates. But for some people, trying could mean 9, 10, 12 times. Very few people can afford to do that, whether emotionally or thinking of even the finances involved. The truth of the matter is that there is no limits to the number of IVF cycles you can do. No limits. I even tried to check literature, no limits. You can do as many as you can, because we know that cumulative pregnancy rate increases as the cycle increases. Next slide, please. So, a message to the doctors and fertility specialists here. We know it's very, very traumatic to you and can put you under pressure. But when you have a patient with recurrent implantation failure, it is important that you take out time rather than generalized treatment. It is high time you individualize that patient. Really, because she would have had like repeated failures, you have the advantage of hindsight. So going through each cycle that failed and trying to see how you can improve on it will help you. Also, liaising with colleagues is also very, very helpful. Next slide. Being open with our patients to say, look, okay, they said this thing, it helps, but it's not 100%. Can we try it? Just being open to the patient that, we've tried everything, but I came across this. Can we just try it, to see whether it works? And finally, for the doctor, I know the training, and because we tend to help people, we feel like superstars. But you must always remember that you are human and you are not God. To the patient, it is always very traumatic when it is announced that it didn't work. Because even as patients are walking into the office, you can see some people, the fright on their faces. And sometimes you also hope that you have good news for them. But as they are frightened and they are so anxious, it's even worse when you don't have that news and they, break down and everything. So it can be very traumatic. But this is the time to have support groups. You can't do it alone. You actually cannot do it alone. It's important for you to join support groups. When you hear, sometimes you think we're the only ones going through a particular challenge. But when you hear the stories of other people, it encourages you to forge on. So I want to encourage every woman here that is in this situation. It's good to join hands with other people who have gone through it and let them walk with you. And finally, sometimes when patients talk, they sometimes complain about the doctors, especially if you are seeing them for the first time. They've just changed clinics. And they say, oh, this doctor, as if blaming the doctor. I just want to leave you with this last word. That sometimes when the doctor keeps a straight face, it's not that the doctor is not sensitive. It's just that the doctor is as equally confused, embarrassed, and traumatized as you are. Thank you.
Thank you very much, Dr. Guru. I remember when I first started in the field of ART, I think the most difficult part of this space is to give a patient the bad news. It's always very traumatizing. Thank you very much. All right, I'm going to quickly move on to the next speaker. Running for time. That would be Madame Eme Akenzwa, and she's going to talk about adoption. Thank you very much.
Well, good day to you, distinguished ladies and gentlemen. It's a pleasure to be here. Permit me to start by congratulating Dr. Oluyemisi Adeyemi Beru and the entire ARC team for 10 years of hard work and positive impact in our society. Well done. I've run a business for 31 years, and I know coming this far can be challenging, especially in an environment like ours, Nigeria. My name is Eme Akenzwa, like you heard, and today I'll be talking to you about adoption. But I want to first start by correcting what's on the leaflet. It says multiple IVF failures. I've never had any IVF. I've had repeated miscarriages. I've had 4 miscarriages, and eventually, well, I'll tell my story as I go on. Now, I'm very passionate about adoption and speak a lot about adoption for 2 basic reasons. One, I believe every child belongs in a family. It's their right, it's not a privilege. And in our society, we have several people who do not have children and are looking to God for a child by one means or the other. So my dream is to bring those 2 parties together. And then secondly, like I mentioned, I have been personally blessed with the joy of adoption and have decided to spend the rest of my life counseling people, changing the perception of adoption in our society. I will share my story as briefly as possible. Most people come to the point of considering adoption when everything else has failed. In my case, I had always had a childhood desire to adopt, even from about the age of maybe 8 or something. But it was something I thought I'd do after 3 biological children and, later on in life. But somehow I was pushed into adoption earlier than I had expected. I would get pregnant very easily. It was not a problem. Shortly after I got married, I got pregnant. And keeping the baby was the issue. Initially, the doctors said it was an incompetent cervix. The first child I lost at 22 and a half weeks. And, won't go into too much because of our time, but lost that child at 22 and a half weeks, went on to lose a set of twins, the first one at 10 weeks, and the second one 22 and a half weeks again. I was flown out of the country, it was critical. Eventually, she was delivered, but she lived for only 90 minutes because her lung was not fully developed. And as if that wasn't bad enough, the doctor left the placenta in my womb, which meant, of course, I didn't know what it meant. I was just young and happy going around life. And I went home and started bleeding profusely. Ended up in hospital, went into shock, transfused with blood. And later, we found out that it had something to do with my blood type. I think they said it was rhesus negative. And so you have repeated miscarriages if you don't take an injection after the first miscarriage, but no one knew that. At least we didn't know. But at some stage, a doctor in America said, there's a blood test I want to do on you. And when they did the blood test, they discovered this. So it was 7 years of a lot of pain, 7 years of hopelessness, 7 years of despair. I'm a child of God, but I got angry with God because I couldn't understand what he was doing. It didn't make sense. First time, they said affliction would not come a second time. It came a second time, it came a third time, and it came a fourth time. But did I give up on God? I didn't. Yes, there were days I was angry with him. There were days I was upset. There were days I didn't want to read my Bible or pray. But deep down inside, I knew that he was the only hope that we had. And even getting to this point of knowing it had something to do with the blood was after my husband did a 3-day fast, no food, nothing, and somebody called and said, listen, my daughter had a situation. I don't know if it has anything to do with you. And anyway, that's how we started on that journey. And eventually, they did put a stitch in my cervix just to cover every area. But then I had to inject myself twice every day with a blood thinner for about 7 months. That was very difficult. That was very trying because I'm very squeamish about doctors. When they said IVF, I thought, God, if that was all we could do to have a child, I probably would never have one. I'm very squeamish about doctors and hospitals and everything. So I had to do these injections myself twice every day for 7 months. And to the glory of God, I finally had a son. In 2005, about 4 months before my 40th birthday, a miracle. After that, my husband and I decided that if we were going to have a second child, it would not be biological at all. I didn't want to lose my life. I wanted to stay and take care of this child. I know several people who have gone on and on and on and eventually have the child but die in the process. So after 9 years, we brought home the most beautiful baby girl you would ever have seen. And I'm not just saying that. At the time, of course, we had no idea what was in the gift of this child. She just seemed like an ordinary child, but she's very talented, multi-talented, very intelligent, beautiful, looks exactly like me, more beautiful than I am. And she has brought us so much joy. I'm not just saying that. You know, when people say, is it possible to love a child who's adopted as your own? I would categorically say to you, yes, 110%. You can love a child who you did not give birth to, just like your own child. The other day, I was in conversation with her, and she's very touchy. She likes body touch and all. And she came right close to me, and I was tired, and I said, leave me alone, George. You want to enter my tummy again? Then she turned around and looked at me and said, was I ever there? Because she knows, I've told her, I believe in telling. So there's a very open relationship. And she reminded me that she hadn't been in my womb. That's how much I forget that she was adopted. Having said all of this, I'm aware that there are challenges with adoption in our society. I will attempt to address 3 or 4 of them. First, there's a stigma associated with adoption. And that's what my major job is, trying to do away with that stigma by the grace of God. And what is it? People say, where have you gone to bring that child from? You would hear. It's expected that every woman should be able to carry a child in their womb. And so when you're not able to do that, people look at you funny. I recall once in church several years ago when I was still going through this challenge. And my pastor, Pastor Itai Godalo, at the time, he said, reach out to somebody, hold hands and pray. Just pray for the person. And this woman turns around, grabs my hand, and she says, fruit of the womb, baby. And she went on. And I couldn't believe it. And I thought to myself, so my name is now fruit of the womb. I don't have any other need in the world. And honestly, I had come to the point where it didn't matter again. And I was looking for other things, but she just assumed that. I went away a bit upset, got into the car. My husband said, don't be upset. She doesn't mean any harm. She just really thinks that's the only problem you have. So what I say to people about the stigma is adoption is God-given. If you're a child of God, God first adopted before man adopted. He adopted us into his family. We're not originally God's family, but he adopted us. It's the Israelites who are. He adopted us into his family because adoption is beautiful. And he sent his only begotten son, Jesus, through adoption. Joseph was not his biological father, but Joseph decided to father him, cover his shame and his mother's shame by adopting that child and taking care of that child. So there's no shame in adoption. Adoption is beautiful. God's ways are past understanding, but are truly perfect. The second one is that most people are worried about the opinions of others. What will people say? And the comments, most people will, don't go and bring a child into this house that you don't know where the child is from. Well, God will still give you your own. Go and adopt, then God will still give you your own. The one you adopted is whose own? So you hear all kinds of things being said by people, negative comments. I would advise that you, first and foremost, find out what God wants you to do. Does God want you to do IVF? Does he want you to adopt? What's God saying in this? Not the opinions of men. They will not be there. They are not there when you're crying in the night and cannot sleep. They're not going to be there for you in your old age when you don't have anybody to sit by you or take care of you. So it's a decision you have to come to yourself. What's really important to you at the end of the day? And most of these people who have all of these opinions, What parts do they play in your daily life? Are they there for you? What value do they really add to your life? So you must think about your life properly and decide what's important to you. You know, and something else, there's a proverb that says it's how you carry your calabash that other people will carry it for you. When my daughter was coming, we had made up our minds to really, really celebrate her and cherish her before she came. We went to town, of course, with doing her room in a way that only was befitting of a princess. We didn't stop there. My older sister called one day and said, you want to bring a princess into this house? I beg, paint the whole house, change your chairs, do something special. And really, we overdid it to some extent. And beyond that, 3 months after she came, we decided to have a big dedication for her. And invited everyone who mattered to us to come, because it was our way of announcing her. And it was beautiful. After that sort of thing, who is going to come and have an opinion for you? What gossip are they going to gossip? I've gossiped everything already. We've announced her in the way that we want to announce her. So there's no whispering. You can't whisper about anything because I'm the one even telling you about it. So what do you want to do? Do you understand? So we really need to know what we want out of this life and to do it. And so she became a celebrity of sorts in my son's school, in church, everywhere. All the grandmas in school will pull me aside and say, hey, my daughter, well done. God bless you. God will do this. God will do that. It was prayer, prayer, prayer. And I found when you're honest and do things God's way, there's nothing bad that can come out of it. But when you hide it and sneak this child inside the house and start lying to people that you got pregnant and you had the child, you know, it will be one lie after the other. And I've watched people, there's a big person in society who's done it. And it's so disgusting, to be honest. You know, because it was an opportunity for her to have used to really, and interestingly, has about 4 biological children, but needed a boy. And brought this child in all of this controversy. And right there, when they were having his dedication, everybody was whispering. Everyone knew it was a lie. And yet she just seemed to be happy fooling herself because she wasn't fooling anybody. People were talking about it openly, you know. So what God does has no shame, you know. So if you ever think of going that route, it's beautiful to do so, but go into it saying you're going to do it properly. We have people coming to the orphanage. In those days, Alausa has changed the ministry. They would send people to us with big tummies. And when they come in, we're like, what are you looking for here? You're pregnant. Before we knew that, they were actually advising people to wear tummies, you know, and they had different sizes to progress as, you know, make the pregnancy progress. And so we would say to people, we're not going to deal with you with that lie. There's no shame here in what we're doing. This is very honorable. This is of God, you know. So be careful, you know, because what you start, you might not be able to finish. Then there's government bureaucratic red tape. Of course, you know, I hear most people talk about what happens in Alausa. Oh, it takes too long. The process is very long. This challenge and that challenge. Well, when you consider the joy of having a child, those should pale into insignificance or almost. You know, I understand that you've waited for several months or several years trying to have a child, and then to come across this hurdle again can be another challenge. But everything that has a beginning has an end. So start. Then the last point is the lack of historical information, which bothers a lot of people. Where is this child from? No history. How do I know what might be in this child's blood? What could happen tomorrow? Well, what I say to people who bring this up is, you have an option. You can actually ask to adopt a child that has history. There's some children who have been brought into orphanages by their biological family to be given up for one reason or the other. It could be poverty, it could be teenage pregnancy, whatever. So you have those children, and usually when they're brought into orphanages, there's some history taken down so that a prospective adopter has history when they're taking the child. And then the other thing I ask people, What do you know exists in your own bloodline? There's some issues that are silent for generations. And then suddenly you have an albino child, and then everyone is thrown off. I mean, I'm not saying there's anything bad with it, but you know what I mean? I have a friend who that happened to, and she's a wonderful advocate for that. But of course, initially it was very challenging for her. Or one thing or the other happens, and then you begin to go back now to ask questions and find out who had this in our family. So we don't know what we're carrying in our blood or in the blood of those people we've married. It's only when the situation occurs. So whatever you would do, if you had that problem with a biological child, then you should do the same with a child who's been adopted. Lastly, the fear I hear most people, which is part of the historical part, is that what if this is a mad woman's child? That's a real fear for a lot of people. You know, is there anything too difficult for God to do? Is there anything too hard? So if you had this child biologically, and tomorrow the child has some issues mentally, what do you do? Throw the child away? You wouldn't. I'm sure you would not. You know, so let's deal with an adopted child just the same way as we would with a child who we have, or let's deal with an adopted child the way we would with a biological child. In conclusion, I want to say that adoption is not for everybody. Despite all that I've said and the sell I'm trying to do, it's not for everybody. There's some people who know that they cannot love another child, the way they ought to. So don't bother to adopt. Be honest with yourself and don't put any child through misery. Also, be adequately informed before you adopt. You need to know all the things involved, the implications legally and otherwise. Be prepared to let the child know about the adoption. That's something I speak very passionately about also. You know, God has a bigger picture than having a child for your pleasure. Hannah in the Bible desired a child for her pleasure like any other woman. And also to ward off all the tauntings from Peninnah, her husband's wife. But it was not until the point where Hannah realized that God himself also had a need, that she had a miracle. She vowed to give that child to God when God gives her the child. And so at that point, her womb opened because God had a need. What you're going through now, does God have a need that you can fulfill for him? Just like, what's his name? Pharaoh's daughter did with Moses. And Esther's uncle did with her. They moved these children from their biological environments into the palace, into another environment for them to be able to fulfill destiny. So perhaps what you're going through, like what I went through, it's not a mistake. Maybe God wants to use you like that, to take a child from one environment into another environment to fulfill purpose. Can you look beyond your own need? Can you look beyond your pain and look at God's needs also? Hannah's son turned out to be one of the greatest prophets in Israel, Samuel. Because Hannah was able to see what God wanted to do. If she hadn't gotten to that point, I tell you, that child would have been kept under her bosom forever. She would have kept the child close to her. But after the child was weaned, she released the child because she knew it was not hers, it was God's. We're only custodians, just for maybe 50 years or so, and then we move out. So think about it and see. Some of us, some people like me, you might be one. God has called to work this journey so that someday you'll be able to stand here and give encouragement to somebody else that with God, nothing is impossible. God bless you. And I pray that your journey to parenthood will be short.
Thank you, Mrs. Akanzwa, for that wonderful story of yours, and congratulations. So I have two more speakers, but I'm going to have to turn over the mic to a lady that has a testimony to give, and she would like to do that now because she has to leave early. And that's in the name of Mrs. Uchechi Akinwale. Are you here? So let's welcome her to the podium so that she can give her wonderful testimony. Thank you.
Good afternoon, everyone. Okay, so it's really good to be here, and just listening to everything that has been said, I was seeing my story. Of course, like we all know, no one ever gets married and thinks that there will be a delay, talk less of a long one. The first time I started thinking about whether or not there was a delay, I think I asked a colleague of mine at work. She had just had a baby, and she said, she really waited. And I said, how long did you wait? She said, 2 years. I said, 2 years, that's short. But this time, I think I was just married for about a couple of months, right? So for us, in the first year, we decided to just, young couple, enjoy ourselves. By the second year, the enjoyment was getting longer. By the third year, of course, my parents and in-laws started asking questions. And I didn't know what was going on because we were going from hospital to hospital, and they just said it's unexplained. And for me, that was mysterious, as in, please give me a reason. You can't just, I knew that I didn't have a funny lifestyle because, sometimes, that mindset that if you get married and it's not happening, you did something. I was a Christian, I was raised right, but I said, no, something is wrong somewhere. So the story started. I went to 6 hospitals in Lagos, Nigeria. I don't know why, but I just had this conviction that it was going to happen, and happen in Nigeria. Most of my family is based abroad. For me, the only reason then actually was that I didn't have the peace from God to travel to do it, and I didn't want to leave work because I knew I would be bored. So I started. I went to the 1st, 2nd, 3rd, 4th hospital. And these are big hospitals, these are good hospitals, and I'm glad that, we have a lot of doctors here, so yeah, I met a lot of you. Sorry, I didn't mean to come out that way, but yes, I went round, So I understand what Dr. J was saying. I know it was frustrating, but there were just different issues. And when she was talking and she was giving the reasons why these things would not happen, uterine lining, I had that. I had adhesions. I had fibroids. I had done a surgery for fibroids. It was successful, or so they said. But still, there were issues. I think I saw Dr. Misha King. He did several hysteroscopies for me. Bless you, sir. And they were always so nice. So let me cut the story short and go straight to before I came to the ARC, right? I had gone to a nice hospital that I had been referred to by another nice hospital, and I got there. He did the first one, full IVF now, and then he stopped halfway before the transfer. I think he saw a polyp or something. I said, okay, I had never heard it. This story, my journey just tells you that there's so many things that you don't know about. So I come from a family of 5 girls, and I was the only one who had to wait as long as I waited. And when I would tell them I went for a checkup, I'm taking injections, I'm injecting myself here, they would scream, and they said, no, it's not possible. I said, sit down, there's so much you don't know about. But so I started walking the path. In all of this, I knew that there would be joy somewhere at the end of the tunnel. I just didn't know how. But I was willing to do everything I had to do. I was that dogged. But even the very strong people, you get to the end of yourself sometimes. So the hospital I went to before I got to the ARC, because my husband travels a lot, we had to do a lot of sperm freezing. And for this particular cycle, we had done everything was going well, and we were about to book me for my transfer. And then they said, hey, when is your husband coming? I said, doctor, what is he coming for? He said, when is he coming to give us the sperm? I said, something is wrong somewhere, sir. Please remember that we did the sperm freezing and you have it. He said, your husband's sperm in this hospital. We don't have it all. He started looking, and he called the embryologist, and in that moment, I was just saying, Jesus, is this my life? How did I get here? So they searched and searched and searched, and then called the embryologist and called this person, called that person. I was just crying. I called my husband, who was a million miles away, and I told him, and he was furious because they were asking me, please, can you tell Oga, can he quickly come so that, and I'm like, so eventually they called me and said they found it, go ahead, let's continue. I did it, but my mind was shaky because I wasn't sure what was going on. They were not honest with me, and I know someone spoke to that, be honest with your clients. I feel like they were not honest with me. I don't know what happened. I feel like they wanted to save the day and just said something. Anyway, I went, but I knew it wasn't going to stick. It didn't. Now, the part that blew me away was the day of the transfer, just before, he called me and said, Akinwale, don't worry. If this one does not work, the next one will do it for you half price. And I said, okay, that's it. I just thought there's no even point even doing the transfer. Don't bother because I already know. When it becomes this commercial, I don't see how God is going to work because my own mind too had already left, and I said, nah, this is not going to happen. You can't hear me. Sorry, I'm so sorry. Okay, so after he said that, I went ahead, to fulfill all righteousness, and we did the transfer. Of course, it didn't work. Now, while it was done, of course it didn't work, the numbers were rising. That was then my 5th failed IVF, and I was tired. So I remember in January of 1 year like that, my husband and I were talking, and I told him I'm tired. I've done 5. I don't know what's going on. I've tried everything. I hadn't tried surrogacy then, but I felt like I had tried everything that I felt comfortable to try. And I said, when are we going to stop? And he said, as long as God continues to give us the resources to go ahead, we would. I said, okay. And he said, as long as your body can take it, we will go ahead. And then he said, as long as you still want to. I said, okay. I bless God for the supportive husband he gave me and the resources he gave us. But I knew that, yes, the resources were there, but it was at a cost. There were projects that we had to suspend. There were things we had to cancel just to keep going. I felt bad for him. So we'd go to church, and my church, you would park your car somewhere and then get into the church bus to take you to church. And then there'll be families carrying kids, and I'll look at him, looking at them, playing with them, and I'll just feel like, oh God, I'm the reason why this guy doesn't have kids. I felt very bad about it. And then I had 2 friends, actually, who had told me about the ark, but at that time I was like, all these hospitals that say they are churches, which one are you? Are you a church? Are you a hospital? Please, I like to be I don't like middle grounds. You can't hear me again. Okay, so I was saying that at this time, too, I had friends who had used the ark successfully. In fact, both of them had twin boys, and they had told me about it. But I didn't like the idea. I said, are you a church? If you're a church, let's know it's church we're doing. If it's hospital, let's know it's hospital. So I never really thought about it. But in January of that year, after that failed cycle in December, I don't know, I just thought, what do I have to lose? Let me try. So I went in there one day in January. I walked in with my husband, and when I walked in, I knew that there was something different. Cut the long story short, we started. Dr. B started talking to me. She got my history, wrote everything down, and then she said, okay, we will try again, but this time we'll use a surrogate. When she said that, I switched off. I think my husband heard everything else that she said because I really wasn't interested. For me, I didn't just want to have kids. I wanted to carry children in my womb, which is why I felt adoption was not for me. Surrogacy too, I felt was not for me. I just wanted to have children. I wanted to feel, maternity clothes, all the things that women want to feel about being pregnant. Of course, without the morning sickness and all of that. That's what I wanted. Yes, so when she said that, I tuned off. But my husband continued talking to her. We got home. I said, I'm not doing that surrogacy. I will try IVF because they look like they know what they're doing here, so let's try. So I started a cycle without a surrogate, and we started all the new things I was hearing about. ARC, they are very, very, in tune with what's going on. There's technology and there's God. I was attending that Hannah's Room Fellowship religiously because for me, that was more therapeutic for me, even more than the actual treatment, because I used to meet with God there, and I would hear God speak to me. I would hear God give me names for my children, and I would just wonder, what is going on? I'm seeing my children, but nothing is happening here. So after all of those big things they did for me at the ARC, I knew that definitely, they've been missing this in all those hospitals, so thank God I'm in the right place now. And then we did it. And I did the 2 weeks wait, which is the worst thing, the worst time for any IVF patient because you don't know what to do, you don't know how to count, you don't know, you're just really just there. So we did it. The 2 weeks passed, and then they called me to come to the hospital, and I went and I sat down, waiting for the results. And I walked into Dr. B's office, and she said it failed. Honestly, something died inside me that day. I think it was hope. Something died. It was terrible because I don't know what was more painful. Was it everything I went through? Was it the hope I had? Was it the money we spent? It was just bad. So I switched off. I don't want to talk to anybody. They were calling me, how are you? I said, please just leave me alone. I left the country. I went to do a course in Harvard for a few weeks or so, spent Christmas with my family there, and then came back. By the time I came back, my head was now clear, and I knew that, okay, let's try again. But this time, God told me He wanted me to be more spiritual about my journey than scientific or medical about it. So I changed my strategy, and I said, okay. Now, I also heard a testimony. I think ARC had done this Thanksgiving service or so in December. There was a woman who came, and of course, she came with her baby, and she was sharing. Usually, when I see people with their babies, I'll be wondering, God, when? It used to feel like a dream, like, so this thing can actually happen for people. So her testimony, she said one thing that she used to do was anytime before she sees Dr. B, she would pray, and she would say, God, please speak to her, give her the wisdom for my situation. So I adopted that. So before any appointment, I will pray and say, God, you are the one who is doing this thing, so please tell her what she needs to do. Before I meet Dr. Mishakin for hysterectomy, so I did a lot. I would tell God, whatever they need to see, polyp, whatever, just show him what he needs to do. So that way I relaxed, knowing that whatever was happening, it was now God that was doing it. So I went back, and Dr. B said, let's do this thing again. I said, okay, but this is my last one. After this one, whatever happens, I'm not doing it again. That was going to be my 7th cycle, and I just felt, look, 7 is more than enough. Are you counting the money? Are you counting the pain? Are you counting the anxiety? It was just too much. So I said, this one, no problem. They say 7 is a number of perfection. Let it just go down in history that I even tried. But this one, she said, we'll use a surrogate. I said, yes, ma'am. Let's start. Because, I had given up. That's the truth. I had given up. Now, she had told us since that the beauty of surrogacy is that, you will relax because it's not you, it's the surrogate who is doing all the work. I said, okay, that's good. So honestly, that cycle, I relaxed. I said, Shebi, I'm not the one that is carrying the baby. It's the other person. I am the backup. The surrogate is the real person. That's good. They found the surrogate, and then they called my husband and I to come and sign the form. And I think I met her. She's the lawyer. Dramatic day for me. I'm a lawyer, by the way, so please listen carefully. So I entered her office with my husband. Now, the surrogate had already signed the agreement, and then she gave us the agreement to sign our own bits. My husband took the pen, and she just said, where do I sign? And he signed everything. And I was looking at him like, just like that. That's supposed to be me. Somebody's not supposed to carry. Why would you just sign like that? So I felt that in me, and it was only until about, I think, 2 weeks ago that I asked him, that day, why did you sign so quickly? And he said, babes, at that point, it's either we're doing or we're not doing. So really, what's there to think of? You know how guys can be very functional. So I said, okay, no problem. For me, as the lawyer that I was turning the pages. I was looking for something. I was looking for a fault that will make me say, I'm not signing this agreement. But I didn't find anything. It was a perfect agreement. From one lawyer to another, it was a good agreement. That was good. So I got to the place where I had to sign. And then I saw that our surrogate had already signed. And when I saw her signature, my heart broke. And I said, God, so this thing is really happening. So this is the person that is going to carry our children. I signed it eventually. And then I went back to God. And I cried and I cried. And I kept saying, this was not the plan. This was not the plan. And God asked me, which plan are you even talking about? My plan or your plan? Then why do you really think that the only way I can give you children is if you get pregnant yourself? Why are you feeling so important? Why are you overestimating your own self-importance to think that I cannot give you a child through a surrogate? And I said, okay. It was that day I understood the prayer that Jesus prayed when he said, if this cup can be passed away from me, let it happen. If not my will, but yours be done. That was my prayer. And after that, I just said, okay, that's fine. So we went ahead. I would check and follow up with Bingpe. How is it going? How is the surrogate? Everything is fine. Everything is fine. Now, on the day of the transfer, that was the first time that on the morning of a transfer, I won't be pulling out my hair. I was so calm because, my mindset was, this is not me. This is not my cycle. This is for the surrogates. So they should better take care of her and make sure that she's fine. My husband was billed to travel that day. So before he traveled, I asked him, okay, it's today, what do you want from this cycle? The surrogacy and everything. He said 2 boys. I said, okay, but you know me too, I'm the backup. So maybe just to fulfill all righteousness, just come and put your hands where your mouth is. So he came and placed his hands on my tummy. And he said, we prayed together, and he decreed 2 boys. I said, okay. And that was it. So I came to the hospital that day, and they said it was time. And then I asked about my surrogates, and they said, don't worry, we'll do your own first. I said, okay. We went in, now I've done this how many times? This was my 7th time, so I was a pro, You go in, they do the transfer, Dr. B prays, you say amen. It was great. And then she told me what I've heard so many times, this was a beautiful and smooth transfer. I said, okay, thank you very much for that vote of confidence. And of course, when she prays, she will say that we've come to the end of ourselves as man. So God, all the things that they always say in good hospitals that are, Bible-believing and faith-based. So that happened. And then I came out and I asked again, I've done my own, so how far with the surrogate? And then I heard that the surrogate did not show up. Yeah. And then, do you know what? I started laughing. And I said, wow, God, nice one. Nice one. You got me there. And the ARC guys were like, don't worry, we'll find another surrogate, we'll keep your this, we'll do that. And I just said, just hold on. Something is going on here. Just hold on. My husband had traveled. I called him once I got into the car. I said, I've done it all, but guess what happened? He said, what? The surrogate did not come. He started laughing too. I said, they want to find another surrogate, sharp, so that we can steal. He said, no, tell them not to. And when he said that, I knew that we were speaking the same language and we had the same conviction. I said, okay, that's good, because I already told them not to do anything. What are we going to do now? He said, let's just wait. If it's the normal 2 weeks. I said, yes, normal 2 weeks. Okay. So for the first time again, I got home because I had taken leave off work and I just was going to enjoy myself and start getting used to the surrogacy idea. Now, what I had struggled with surrogacy was, how is it going to be? Somebody is pregnant, carrying our child. Okay. How will I tell them in the office? What will I do? Will I just show up? And I kept talking to Fumi, and she said, does it matter what people think? I said, it matters. What will I say? How will I do it? And then I asked my husband, and he said, you're just stressing yourself. It doesn't really matter. I said, okay. I asked my best friend, and she said, you won't be the first. She called different names of people that had done it. I said, but they are not me. My own is different. This is not the plan. And everybody I spoke to, I called my sister-in-law as well. And I thank God for, being married to a good family. And she said, sis, is that the only thing? I said, yeah. She said, it's not a problem now. I said, your family people, how would they be? How would daddy take it? And she said, it's not a problem. It's not. It's going to be your child at the end of the day. So please. So I had peace from all those corners, except my own corner. But once I now prayed and had that, peace with God, I just moved on. So I stayed home for the 2 weeks. And then towards the end of the 2 weeks, like Thursday or so, I was tired of staying at home. So I went back to the ARC. I think I was meant to take an injection or buy some drugs or something. And then I started talking to Uju and Fumi. And I told them, guys, this one, I will come in the morning because I resume on the same day. I will come in the morning to do my test and not come back. I don't care what the result is, I'm not coming back. Because I can't go through that torture of staying there, waiting. And again, because I had been at home, I didn't feel anything strange. So I already knew that, okay, once again, we've come to the end of the road and it has failed again. Pinkpei called me, how are you doing? Fine. Any nausea? No. Any vomiting? No. Dr. B called me, Uchechi, how are you holding up? Fine. Are you feeling anyhow? No. Do you have this? No. Do you have that? No. Okay. Uju too will call and ask questions. When they all finished, I knew that, well, maybe they're asking me all these questions because if I was pregnant, like by this 10th day or so, I should already know. So, well, my case is concluded. There's something else going on. Maybe I will now have to go back and we'll do the surrogacy that I've been running away from anyway. And then it was a Monday, I resumed. I came to the office first. Uche in the lab was there. She took my sample. I said, bye-bye. I saw Abiola too, and I told her, tell your people when they come that I'm not coming back. Just call me over the phone. Around 11, Uju starts calling me. I'm like, I already told you I'm not coming back. She said, please, please, please. Dr. B said you have to come. I said, I'm not coming. After a lot of that, I eventually showed up. And you know how they are, the ARC? Their faces will be very blank. You can't even guess what the result is. So I was trying to, but nobody told me anything. I sat and I went inside Dr. B's. And by this time, of course, Monday I had resumed. I had stopped taking my drugs because I was so sure that, I wasn't feeling anyhow. So clearly it didn't work. I just didn't want to come and have that conversation with Dr. B so soon. I wanted to just wait small and then we'll start talking about the next surrogate. But out of respect, it was only respect that made me go. So I got to her office and then she said, how are you feeling? I said, okay, normal. I said, you're not feeling anyhow? I said, no. In fact, I've stopped taking my drugs. And she said, why would you do that? I said, because it's the same way I feel after all this time. She said, no, that's strange. I said, why is this strange? She said, because you're pregnant. And I was like, oh, Dr. B now, Dr. B. She said, but you're pregnant. And she kept looking at me, but it didn't sound like, She said, you're actually pregnant. I said, no, Dr. B, no. I didn't move, I didn't cry, I didn't jump. I said, then the lawyer in me came out again. I said, Dr. B, you have to show me proof, evidence. And then she called Uche from the lab and told her to bring the test strip. I heard Uche running. She ran and then she showed it to me. She said, give her, give her, give her. And then I saw it for the first time in my life. I saw 2 strips. 2 lines on the strip, and then it dawned on me, wow, I'm actually pregnant. And that was it. And that was how I got pregnant. And sometime in the pregnancy, I started bleeding. I called Binkwe and she was asking me questions, and later I came in. Once Dr. B saw me, she said, why are you worried? Something God has already done. Why are you worried? What are you shaking for? And she checked, and she said, everything is still fine. And then I went again for another check. And they said they saw 1 heartbeat. I remember talking to Binkwe afterwards, and she said, how did it go? I said, they saw 1. And I was very disappointed. And she said, what's wrong? I said, after everything, how will God give me just 1? And she said, sis, it's not like that. So God will give you what he thinks you can handle. I said, I know, but it's not, now, I've really... And she said, don't worry, don't worry. Then I went again for another check. And Dr. B starts acting strange. She's like, what's this? This thing was not here before. Then she calls Dr. J. Dr. J, come and look. And my heart had already gone. Because I said, oh God, what is it again this time? I said, please, man, what is it? And she said, don't worry, don't worry. To cut the long story short, they saw 2 heartbeats. From 1, it became 2. Then, when it was clear that I was actually carrying twins, she asked me to leave the country immediately. In my mind, I said, this Dr. B, why are you always doing this? I still have to work. Because I was just a few weeks pregnant. And she started saying, leave the country, leave the country. I told my husband, I said, yes, I agree, leave the country. Before I knew it, they had put me on the plane. And I said, how will I even fly? I can't sit down. My condition is delicate. And he said, no, you will fly business. I said, I'll save your money now. It's not that bad. He said, no, you will fly business. So I flew, and I literally stayed, flat the whole journey. And I got there. And I knew that this was God, because once I got to the hospital, there was a problem already from my very first appointment. And they switched me to another hospital in America, a bigger one. And then, to cut the long story short again, they said there was twin-to-twin transfusion. I'm glad that I'm surrounded by doctors, so I'm sure they understand. But it was a precarious situation for me because it meant that I could end up losing 1 child or both. So I would literally go to the hospital every weekend. They would tell me, come with a bag because we can do the surgery any moment from now. They were going to try and do a surgery to see if they could do a surgery actually on my placenta. And I just thought, can it get any worse? So I called Dr. B, and she said, she would always pray with me and calm me down, tell me to just do exactly what the doctors were saying I should do, and I would do that. Somehow, that diagnosis just changed. And they said, no, you don't have twin-to-twin transfusion. The babies are fine, and you will make it. And that's how, to the glory of God, I carried the pregnancies to 36 weeks, and God blessed us with 2 beautiful, bouncing baby boys. Yeah. So, My name changed. I walked into ARC as Uchechi Akinwale. Now I'm Iyabeji. And I thank God for that.
Thank you very much. Fantastic testimony. Thank you. All right. That was an awesome story. And we're very happy for you. When are you coming back for another set of twins? All right. So I'm going to quickly move on to our next speaker. I'm going to save the lawyer in the house for to the very end, because that's an interesting topic she's going to be talking about. So I'm going to call Mrs. Yemi Kukwola to give us, yeah, go ahead. You're welcome. I'm going to talk about adoption as well.
Hello, everybody. Dr. Bero, congratulations. I was there at the beginning because my daughter is 9. And I can't believe that we've only known each other for 10 years. And to everybody here who's in this field, I want to say a big thank you to you for all the smiles, all the laughter that you've brought to different people's lives. My journey is somewhat different. I did not have to wait so long for a child because I got married in my 40s. But from day one, I knew that it made sense that I didn't just wait and sit and, just do the normal whenever I get pregnant. I knew that time was short. And so shortly after I got married, somebody had been to a few fertility hospitals, and I'll live there. Either my husband will be like, I don't like that doctor, or I'll be like, I don't like that doctor, or we'll both be like, we just don't like this hospital. There was just always something. And then someone random just said, oh, there's this new place, the Ark. And my husband was like, so that they will use us as experiments. But we went. And when we got there, we had started going before we got married. Not because we were actually not even having sex. But we just wanted to, because we were both advanced in age, we just wanted to, just not waste our time when we finally got married. And then we met Dr. Bero, and as soon as we stepped out, we were both like, this is the place. Now, before I get into my own story, I would like to give you a bit of background about myself. I had an aunt, my mom's younger sister, who never had a child. And I saw the toll it took on her, on her relationship with everybody else. And then I just got to meet a few other people. You know how when you're younger, you just seem to know people who are believing God. Some people, their marriages ended, and things like that. And then when I was serving, I think, there was this journalist called Mary Ellen Ezekiel. I read her story of her. In fact, anytime I think about it, I want to cry. And she was writing the story of how she arrived at her first birth. And it was raw. Then I think she wrote in Newsweek or one of those things. I finished reading it. I went into my office bathroom and I cried. Bear in mind, this was my youth career, so it wasn't even that I was thinking about it, but the emotion made me realize how deep my auntie and all the other people that I knew, what they went through, and I made up my mind that this was not going to be my story. So when I went, before then, I'd had fibroids, people would be like, you must be pregnant. I'm thinking I can't be pregnant because I'm not having any sexual relationships with anybody. And then I would go, they'll remove a fibroid, it's like a 3-month-old baby. It's like, so I'd had quite a few surgeries before, in my younger years. And then I met Dr. Bero. Before then, I went to a doctor. And, I'd had all you doctors know, all those painful injections, ACG, something, all those things. I was already thinking to myself, is it that I'm going down this path of what's her name again? Mary Ellen Ezekiel, me, yeah. And I was like, no, this is not going to be my story. So when I met Dr. Beru, the first day they were doing an exam, I could hear her tell, I think it was Dr. Oguru then, and they were saying, come and check this thing. It's as if the cervix is, I was like, not me and you are doing this journey. We prayed, as usual, we prayed, we did everything. Even now, when I take injections, I cry. I had to take IVF injections. You have no idea the toll that took on me. Plus, I'd been a Christian from my teenage years. My only vision in life as a child was to have my own house and be a mother. I don't know whether anybody can relate. When you're younger and your mom does something and you just imagine yourself, when I'm a woman, I'm going to be married, my children, this is how I'm going to talk to them. So I had always had that vision of children. And so I could hear her saying, this place is as if this cervix is lower. That I'm thinking, it's not me and you people that are doing this thing, but I had no choice. Anyway, so we went through the IVF stage. I did all the injections. That 2-week wait that she spoke about, I could not jump. You know how you're walking, you're afraid, you don't want to move anything so that the implantation is not disturbed. It was really a try. And then we got there. And then Dr. Beru was like, these things happen. And she went on, in short, it had failed. I took it, I'm sure she thought I was a bit indifferent, because I was like, okay, fine. So what's our option? She was like, well, she thinks we can still try. And then if he fails again, because before then, like I said, I'd had a few surgeries, fibroid surgeries and all. Then maybe I want to look at surrogacy. I was just thinking to myself, I refuse to go down this journey of depriving myself of life because I want a child. She told us all the options. She told us you can do IVF, donor sperm, IVF, donor egg, surrogacy. She just went, we took everything on board. When we got home, for 2 days, every time I opened my mouth to pray, I was just crying. My husband was at a loss. Because of the two of us, I'm the more stoic person. Once I opened my mouth to pray, tears. I felt abandoned by God, because I just thought, how can the one thing I've believed you for all my life is children? How can? I can't go through this. I just went on and on. Eventually, I got my groove back. They called me tired. I said, I'm coming. So anyway, my husband and I will now decide to pray about it and figure out what our options are. One, IVF is expensive. So I knew that we could not do it continuously. Two, the emotional toll that it took on me, I was totally unexpected for it, because nothing had ever shaken me like that before. And so we prayed. We now said, okay, you know what? You go and talk to God. I'll talk to God. We will figure out, let God tell you. And then you write down what you feel we should do. I will write down what we feel we should. So that it will not be as if we're influencing because of what you said. Let me just agree with you, kind of. And we went our ways for 2 weeks, praying and all that. My mind was now going towards adoption. I knew of only 2 people who had adopted. At least, I use the word no, because a lot of people don't declare. So one of them had children before. Sorry, one of them adopted, then subsequently had children. Another just adopted. So I went to meet my friend, the one that adopted and then subsequently had children. So I said to her, and sorry, I forgot this part. My husband was in his second marriage. So he had natural birth kids. So I was a bit worried about, so if we adopt, will you love this one the same way? So I had a lot of conflictions, but I felt that God was leading me towards adoption. Anyway, so I went to talk to this girl. When she heard, she laughed. She said, Yemi, first of all the tribes in Nigeria, Yoruba are the most easygoing when it comes to this adoption matter. It doesn't faze them. That for other areas, she's not Yoruba, that for other areas, there will be many issues and many, what's it called? I said, okay, so we talked a lot about it. So I said, no, that both she and her husband, they're closer to their adopted daughter. That in fact, her adopted daughter, she had twins after that one. And she said that her natural birth daughter does not behave. My friend is very ladylike, prim and proper. She likes girly things. Her natural birth daughter is a tomboy. So that she naturally gravitates towards her her adopted daughter. I said, so what about your husband? How does he feel? She said that they had a discussion recently. And they were both discussing that. Do they have a problem? Because it's as if both of them, their favorite child is the adopted one. And they concluded that because she was the first one to come, perhaps it was just normal. So I had a lot of discussions with her. I spoke to the other lady who I said adopted, what were her experiences and all that. And then so I went back home and the day came for us to discuss. So I said, write what you want us to do on a piece of paper. I wrote mine and we both opened it and it was adoption. Then the story now became, how do we go about it? We figured out the ministry in Lagos. Everybody told us Lagos State is very difficult. You know, the process is long. So I don't know if this is right, lawyer. I registered in 3 states. I registered in my home state, which is Ondo State. I registered in Lagos State, which is where we're residents, and then we registered in Oyo State, which was closer. Now, there's something that we discovered in talking. You know, after that, when you now start talking to people, you now meet other people who are in your shoes. We now realize that, first of all, if you adopt in certain parts of the country, if you're planning to relocate, or you're planning to get a foreign passport for your child, you will have a problem if you're adopting from certain parts of Nigeria. One, because, doctor, apparently Nigeria is not there's a human rights, child trafficking agreement worldwide. Nigeria is one of the, I think, 10 countries that did not sign that agreement. So it's not automatic. So adoptions in Nigeria are looked at very suspiciously because of child trafficking. And then in certain parts of Nigeria, we discovered you can't even, once you adopt from that area, to get a passport, a foreign passport for your child, it may take you up to 10 years of going to courts, doing different things, because you have to prove to them that it wasn't as a result of baby farming or child trafficking or a displaced child from one of these conflict areas. So with that knowledge, we now went about and we started doing everything that we needed to do. I started, I think the IVF thing was in June, July. We decided on the adoption in September, registered in September, and I traveled out of the country for some other thing. Came back in October, in November, and then in January, I get a call not from Lagos State, from one of the other states. Am I ready for a child? Now, I said yes. They said the child is a baby. I said yes. The child is a girl. I'm fine with it. So we started the process and we adopted. I didn't tell anybody outside of my husband and I, and the people who was kind of like putting us through the processes and all that. Nobody in our families knew and everything. And when we brought the child home, we didn't tell anybody. The only person who knew, I made sure, because somebody had told me about a woman that was lynched somewhere in Surulere because she had done this fake pregnancy thing and then adopted. But when she brought the baby home, her neighbors knew it was a fake pregnancy. Anyway, to cut a long story short, they lynched the woman because they thought she stole the baby. So I was very mindful. Even though I said I didn't tell anybody, I was carrying my driver along to show you how. So our families didn't know, but our driver would know, because I didn't want any, you know how these things can be. So anyway, we came back. When we brought the baby back to Lagos, I sat in my house and I said to my husband, the same way. So he said, oh, I should call my mom. I said, no, the same way when you give birth to a child And it is the man that calls people around to say a child has. I said, that's the same way we're going to do it. And so we got different reactions. I assumed that everybody will be happy for us. We got different reactions. My mom was very happy. She wasn't in Nigeria. She said, oh, can we please not do we told my father-in-law, as soon as we told him, I was like, no, we should not receive any gifts from anybody yet. So he's coming, because this was like, we got back to Lagos about 6 p.m. He's coming tomorrow morning. He has to be the first person to give his granddaughter money. You know, that kind of, what's it called? As soon as he came in the morning, he told us, naming ceremony, 8 days time, my house as usual, all grandchildren, they're named in the house, you know, and that was that. My mother, I told her, she was like, so don't do the naming ceremony yet, because I can't come back in within call. I said, for sure dad has said name. He said, no, I will call him, I will beg him. So we did it in 2 weeks' time. Those were fantastic responses. Then we now had to call a few people who I felt needed to come for the naming ceremony. I called one of my aunties who I still respect a lot, a Christian and everything. She said, does this mean you have given up on God? And I asked myself, the whole process, the whole journey of injecting yourself, of believing God, of trusting God, in what part of it is giving up on God? And I got that reaction a lot from members of my church. My pastor was fantastic, but different people. I remember I was working shortly after, maybe like 2 months after that was I think my first day in church. I was walking, I could see some people coming towards me, and you could see, when you are deliberately trying to avoid somebody and you turn off because you don't know what to say to the person. I could see it happen. And later I asked, and she said, I asked the lady, and she said she really didn't know what to say, whether to say congratulations or not. So I thought, okay, I don't know, I didn't know what to say to that. I was supposed to host a meeting. Bear in mind that with adoption, you're never really sure when you'll get the baby. So it's not like you have, like pregnancy, you have 9 months to prepare and all that. Adoption, are you ready? Yes, we now started. And because everybody I knew that I started talking to, the people were telling me, Lagos State, we've been on it for like 2 years now, we're on the queue. So we were very laid back. In that, like 3 weeks before the baby came home, we had to paint, prepare a nursery, shop for baby. I didn't even have, you know how people do faith things? They buy bib, I didn't have pin. I didn't have a pin. So I had to do all that. So I didn't have time for, a few people came to visit. We did the naming ceremony. And then a year later, we did a massive child dedication. And in all of it, like I said, one of the reactions that I found the strangest was when somebody said to me, I hope you have done deliverance for the child. So, no, it's funny, but honestly, when you understand the pain of somebody coming to visit me, that I have a child, and you say to me, you hope I've done deliverance. It took every love of God in my heart not to walk that person out of my house. I just looked at it that this person is speaking from a place of ignorance. And even now, when you go to hospital history, I don't have. Of course, we had to wait like a year to be able to, I think, was it like a year or 9 months to be able to know blood type. We knew nothing, absolutely nothing. Then my daughter is fair. She's really, really fair. My husband is like blue, black. So even when we're carrying her we're in Lagoon, when we're carrying her, for all the first immunization and stuff, people will be like, are you sure you're the father? I'm thinking, what if we had issue already and the man was saying, can this be my daughter? We just had all kinds of, we had, and I know people who till today, with their 10-year-old, with their 15-year-old, that the Their parents have not accepted the adopted child. They just refused to acknowledge and all. But the one thing that helped me through was I was sure of what I wanted. I was not interested in the journey to motherhood. I was interested in being a mother. And I think, just in case there's anybody here who you're going through, in fact, when this lady was talking about the seventh, what's it called, my mind, I was thinking, why? Why? Because there's so many avenues. Like Dr. Bero said, like Emma said, everything, we're adopted by God. The two most popular figures in the Bible, Moses and Jesus, there's surrogacy involved in Jesus' story. There's adoption involved. Moses, there's adoption involved. You know, it's such a, there's no need to be rigid about how you want to get. It's like saying you want to be very rich. And you've decided that the only way you can be very rich is to become a doctor. And somebody is saying, but I think you're skilled to be an engineer. You're saying, no, I must be a doctor to become very rich. And it's the same way. And I just want to ask, for all the medical practitioners here, it's good that you understand that, like Dr. Oguro said, you're not God. And so the avenue to parenthood for some people may not necessarily be through your medical process. And it's good to be able to look at some people and say to them, perhaps you want to explore this other option. Particularly, like I said, because of cost. Cost is a factor. 2, simply because I didn't want to spend, I was 43 when I got married. I didn't want to spend another 5-7 years believing God for a child after waiting for 40-something years to get married. Now become 50, and even now, I'm clearly the oldest mom in my daughter's school. My friends, one of my closest friends, grandchild is having his first birthday tomorrow. And I have what am I talking about? My younger sisters have kids who have graduated. I'm still in primary school. I don't want to, I just couldn't picture. Can you imagine if I had waited this long, maybe 50 years, and then I'm now just doing diapers. Even when people were praying for me when I had that one to say, Yorubas, I don't know if there's any, there's a prayer they say that Allah will relay. I refuse to say that amen because I didn't want another child. The thought of bending down to change diapers. But I'm really grateful to God. I'm really grateful that I met Dr. Bero because she explained to me, and it's important, doctors, please, you see all these HSGs things that you people talk about, we're not there for that. We're really there just to become parents. So when you're explaining to us, explain with heart. Let us understand that, yes, all these things, you need to know it. Your HSG is low, your what's it called? But we didn't go to school like that. You understand? You have people who are educated in that field. So sometimes doctors, you like speaking way above patients. But in this field, please come down to our level and feel our hurts and our pains. Thank you very much.
Thank you. Thank you very much, Mrs. Popola. Thank you for that wonderful testimony. All right, so I'm calling on Barrister Yemi Akinrele, who is our very last but not the least speaker. Well, I get to talk after you, so I'll be the last. She's going to be talking about the legal ethical issues surrounding third-party reproduction.
Thank you very much. Good afternoon, everyone. Well, I'll stand on existing protocols. We have slides. Is there somebody manning the slides? I hope you're not all too hungry. And so you still, well, hopefully, since you're hungry, I'll have your attention. Okay, so I'll just go on, and I'm sure the slides will eventually come up. The popular idiom says that 2 is company, but 3 is a crowd. With IVF, third-party reproduction, we don't only have the couple involved in the process. They say it's bad enough, from what we've heard, for a couple to be waiting for a child. Having waited for so long, you realize that you are not the only parties that will be involved in this process. And eventually, what we end up having is not just 2 or 3 people, but 4, 5, 6, sometimes maybe up to 7 people involved in this. So what was supposed to be Tui's company suddenly becomes not a party, but a fiesta or a carnival. With third-party reproduction, we have various parties involved. The surrogate is one of the people that has been introduced into third-party reproduction. We also have egg donors, we have sperm donors. Obviously, this takes us out of our traditional belief that a family is just a husband and wife. So we have a lot more people who are involved in the process: the egg donor and the couple, the sperm donor and the couple, or in the case of a gestational surrogacy, the surrogate is also involved. Obviously, this throws up all kinds of conflicts, throws up all kinds of issues that we have to deal with. So most times, we have to ask the question, is all of this legal? What does the law have to say about this? So you can go on to the second and third slide. I have gone through the first 2. The first and perhaps most important question that people always ask me, especially concerning surrogacy, is that, is surrogacy legal in Nigeria? Now, Nigeria does not have any laws governing surrogacy. We have not passed any laws, despite the fact that we have had assisted reproduction in Nigeria from as far back as the 80s. And in terms of third-party reproduction, I'm sure over 20 years now, we've had surrogacy arrangements in Nigeria. Not only that, it has grown tremendously in Nigeria. Unfortunately, we don't have statistics. But I would want to say, I would imagine that we have possibly probably close to maybe 40% of the children that are being born are coming through third-party reproduction in Nigeria. So where our prayer is that our courts and our lawmakers will rise up to this challenge. Now, is surrogacy legal in Nigeria? The way lawyers look at this question is this: there is no provision of the law in Nigeria that determines or has said that surrogacy is illegal. So in the absence of any form of legislation that surrogacy is illegal, then it is determined that it is legal. Also, we look at what does common law say. Common law says that under contract law, 2 parties can come together and enter into legal relationships with one another. And so it is under this guise that we draw up surrogacy contracts, because the contract by 2 people who have come together, they have agreed, one has made an offer, another person has accepted, and some consideration is passing. So both parties have come with the intention that they will be bound by the agreements they have entered into. I want to commend Lagos State in the sense that Lagos State, under the Health Monitoring Agency, has come together with the AFRH also to put in guidelines in place. So Lagos State is the first state in Nigeria that has actually come up with a guideline that says they recognize that surrogacy is being practiced, and they realize that, yes, we should put some guidelines in place so that there is no abuse of this system. So some of the questions that you ask under this type of arrangement is this. We have no laws, so it is the courts that will decide in any situation whether they should enforce that contract or not. Contracts are usually enforced if there is offer, acceptance, and there is consideration. It is as long as it is clear that both parties understood what they were getting into, then we expect that a contract will be upheld, except maybe if there's the issue of undue influence. One party has greater bargaining power than the other, and the other person has been forced into that contract, or the person did not understand what they were getting into. Does the person have capacity, the legal capacity, age-wise, mental capacity to understand what is going on? And for as long as all those ingredients are there and it's not against public policy, then we will find that the courts are most likely going to uphold that contract. I have seen court orders in the magistrate court where surrogacy contracts have been upheld. So this is to put people at rest that if you believe that you're entering into a surrogacy agreement, whether the court will uphold it, it's more likely than not that they will. The courts would look at what was the intention of the parties when they signed the agreement. And if that understanding was there, and also they look at another thing which under family law is very important. It is the best interest of the child. What is the best interest of that child in that situation? And they would, make a decision in that order. Another issue that is thrown up, legal issues that come up are, what is the criteria for determining legal parentage? Of course, this is made difficult because of the fact that we don't have specific laws that say, okay, is it the surrogate that is a mother? Is it the lady who has donated her eggs that is a mother? Or is it the intended parent or intended mother? We don't have those issues. We don't have those clear statements because there is no law governing it. But we can borrow information from other jurisdictions where this has passed. The next issue that comes up or we should be considered is, does a child who is conceived with the use of donated gamete have a right to know the identity of their donor parents? Now, under that Lagos State guidelines, when donors come forth to donate their eggs or sperm, it's usually an anonymous donation. It's the people who donate their gametes, maybe it's your eggs or it's your sperm, are not, when they do this, prepared to take up the responsibility of fathering a child or be called to take up responsibility for that child in the future. And so there must be, when you have an egg donor come through or even a sperm donor, all this information must be passed on to the donor. First of all, that it's anonymous. Secondly, you need to respect the wishes of whoever the person is who is donating. And generally, even elsewhere in the UK, in the USA, people who come forward to donate their gametes are not usually taken as being responsible for that child. And so in determining the issue of who is the parent in the future, at a future date, it should be the intended parents. Embryos, in the case of donation of embryos are frowned upon in terms of creating embryos. In other words, you should not create embryos for the purpose of being donated to a couple. That is frowned upon. And under the Lagos State HEFAM and the Lagos State ART guidelines, it says that donated embryos can be performed when a couple gives explicit permission for the transfer of their excess embryos to another recipient. We expect embryo donations to be altruistic, and no compensation is offered for this. Now, the next question is, does the surrogate have a right to keep the child? And this is where counseling is very, very important. Psychological evaluation of the surrogate is also very, very important. Under the guidelines, a surrogate cannot be enter into a contract for a surrogacy contract except she has delivered 2 children herself. One of the reasons why this is requested is that, first of all, the surrogate herself must have gone through pregnancy, through childbirth. So when she's coming into an agreement like that, she's making a fully informed decision. Secondly, she's less likely to get attached to that child because she has prepared her mind. And that's where the psychological evaluation also comes into place. She fully understands that the embryo that she's receiving is not biologically related to her in any way. We might have been hearing of the recent story of where a surrogate has been saying that she will not give up a child. Now, under that scenario, first of all, there was no contract that was drawn up between the surrogate and the couple that she was having a child for. She said the lady was her auntie, and as she also indicated, her own eggs were used. Now, I don't know, we have lots of doctors in the house, but one thing I know about ARC is this, and a lot of other clinics, that a situation like that is ethically wrong. A surrogate is supposed to, in most cases, be a gestational carrier. In other words, there's no biological connection between herself and the child. So you would not make a surrogate to be a host in a situation where her eggs have been used to create an embryo. Secondly, there was no legal documentation whatsoever to back up what was the agreement between the parties. The lady claims that they discussed this verbally, and she was promised that she would be taken abroad. But at the end of the day, this did not happen, and so she was laying claim to the children. Laying claim to the children because her eggs had been used in the process. So, first of all, I think that's one of the things that we should take into consideration, that we should not really practice traditional surrogacy, but concentrate on gestational surrogacy, and that the surrogate is well aware that the embryo that she's receiving does not belong to her. Obviously, this type of scenario is not new. It happened in America. The most celebrated case of baby M was a situation where a surrogate's egg were used. And at the end of the day, she came back and she also did not want to give up the child. At the end of the day, the court decided that there would be co-parenting, which meant that she was given visitation rights. Eventually, the agency that brought her compensated her, because usually this type of scenarios are really to, they're actually going after the money. It's the money that the surrogate is, interested in. And eventually that baby M grew up and said she was happy to be with her family. That's the intended couple. And after a while, that contact was stopped with the surrogate. Now, what are the ethical issues that come up with third-party parenting? It means that we have multiple parents. We have the possibility of the surrogate being considered the legal mother of the child, the intended parents, and in our society, some people do not accept that. For religious reasons, some people are also opposed to it. The whole idea also of donor means that the word donation means that it should be free. However, we know that when eggs or gametes are donated, there is some form of monetary compensation. Now, the monetary compensation is not supposed to be payment for eggs or payment for sperm. It's a reimbursement of expenses. An egg donor would come, she may have to, of course, she takes transport to come there. She may not be able to work for that day. So that is the idea behind the compensation that is given. And it's not supposed to be that the donor is actually being paid or they're selling their eggs or their gametes. Section 53 or 54 of the 53 of the Health Act says that you can get some form of compensation when you donate blood. Okay, so it's the same way, but some people have said, oh, but you are selling, it's not selling, and there's no law that says that you can donate your gametes and be compensated for it. In that particular section, it's what is determined to be tissue specifically excludes gametes. So that law doesn't even come to apply there, because some people do ask that question that isn't it an offense to receive monetary compensation for donating your gamete? The next issue I'd like to talk about is exploitation. Yes, in many, in a sense, people have said, oh, using surrogates is exploiting women. Now, I just want you to have an idea of figures. Averagely, a surrogate will be paid close to 2 million for a singleton. So I want you to decide whether you think that's exploitation. That's one. Number two, the exploitation that we see, a lot of it also comes from who are the people who are introducing the surrogate. Sometimes we see that surrogates come and they tell you that the agent that introduced them is asking to take part of their money. That is wrong, absolutely wrong, because the agents are also giving some money for bringing the surrogate and also for watching over the surrogate all throughout the period of the pregnancy. Informed consent, that's another issue. People need to be counseled, both the parents, the surrogate, about the process they're entering into, to ensure that they're actually prepared to deal with the emotional issues that relate to third-party parenting. So what are my recommendations? My recommendations are counseling. All the parties need to be counseled. The couple that is receiving donated ovum. Secondly, the surrogate who is going into this needs to fully understand what she's getting into. The surrogate also needs to know what are the expectations of her. I think the process of counseling helps the parties to a great extent. Legal counsel is very, very important. Perhaps what is most important is the fact that the surrogate needs to know that she doesn't even have to enter into this contract, that she's not being forced to enter into this contract. One of the things that is required is that most of the surrogates that you use are people that have had at least 2 live births. So there's no issue of, I didn't understand that this was how it was going to be. The surrogate she has delivered children herself twice. She understands what it is to receive an embryo, to go through pregnancy and deliver. So those things are not easy. They're not easy feats to achieve. So you've been through it 2 times. You can't say you're not aware. Secondly, that the surrogate knows that when she delivers this child, she is not going to see the child. So things like this prepare the surrogate to ensure that she doesn't get too emotionally attached to the child and that she will be willing to give up the child. If these are present and these have been confirmed before, then it shouldn't be so difficult for the surrogate to give up on the child. Also, she will know through this process that she's not biologically related to the child that she's receiving, the embryo that she's receiving. She's also given the option anytime before embryo transfer to say that I have changed my mind. Obviously, after embryo transfer, she will not be able to change her mind. To go through a 3-step level where the agent also has spoken to her, the counselor has spoken to her, and also the legal person informs her. Another thing that is required in other jurisdictions is that the surrogate has independent legal advice. That way, she knows what her rights and obligations are from somebody else apart from the clinic that is engaging her. Of course, there's certain conduct that is expected of the surrogate during the period of a pregnancy. All these need to be put in the contract. All these need to have been documented. And all these things need to be understood by the surrogate. You need to also talk about dispute resolution. If there is a dispute, how do we resolve these disputes? We talk about also confidentiality between the parties and all the other people who are also involved in the process. Now, these rights, duties, and obligations extend as much to the surrogate as to the parents as well. The parents obviously have to assume full legal parental responsibility for any child that is born as a result of the gestational surrogacy. So in a situation where you have some form of defect or there's some congenital disease, the parents will have to still accept the child. There are times when things happen that you never imagined would happen in a situation where there's a miscarriage, there's a stillbirth. The surrogate, irrespective of the fact that there's been a stillbirth, will be compensated. So it's a balanced agreement between the parties. In perhaps one thing that I should say also is that in third-party reproduction, it's very important to engage experienced professionals who can advise all the parties properly. In Nigeria also has become a destination, surrogacy destination, especially for Nigerians living in the diaspora. And so we have a lot of cross-border surrogacy. It's very, very important that the laws, people who come from the UK, from Canada, from United States of America, need to understand that having done their surrogacy in Nigeria, they still have to fulfill the requirements of the laws in the countries that they are coming from. And also to understand that under those jurisdictions, while we do not have laws, specific laws guiding surrogacy, in those countries they do have laws. In the UK, for instance, the surrogate is considered the legal mother of the child. So in a situation like that, if you come from the United Kingdom and have surrogacy done in Nigeria, you will still require the services of your surrogate even after she has delivered. She would have to give up her parental rights concerning that child. And you would have to still obtain a parental order in the UK and before you can be recognized as a mother and father of that child. Another thing is, in such jurisdictions, you have to ensure that the surrogate that you're engaging in Nigeria is preferable that you have a single surrogate, because if you have a married surrogate, if her husband is part of her husband has to be, first of all, part of that surrogacy arrangement. He has to consent to it. But also, the law in the UK assumes that the father of that child is her husband. So these are some of the things that you have to bear in mind. In the United States of America, the laws are constantly evolving and changing, and it differs from state to state. But having come from the USA to have your surrogacy arrangements in Nigeria, one of the things that you would have to do after you have your child is to obtain a consular report of a birth abroad, which is done at the American Embassy here in Nigeria, but you must ensure that there is genetic connection between you, the American citizen, and the child. So in the UK also, in terms of children born through donated gametes, they are also allowed at the age of 16 to make inquiries concerning who their parents were. Initially, at the age of 16, you may not be able to get information concerning the identity, but after age 18, they will reveal the identity. We don't have all those type of provisions in Nigeria, but we can borrow a leaf when we decide to put laws in place concerning these issues. So in conclusion, I'd want to say that, yes, indeed, it's a very gray area in Nigeria. However, what gives us hope is the fact that there is increasing awareness about third-party reproduction. Also in the family courts, especially in Lagos, we have quite a number of enlightened people who will take on issues like this. I have also seen a decision coming out of Edo State where a couple that were not biologically related to a child that was conceived via surrogacy were allowed to adopt their child. So more and more we see that we're receiving favorable disposition to third-party reproduction in Nigeria. As people are getting more and more enlightened, we hope that pushing forward with the help of the Lagos State Ministry of Health and Ministry of Youth, Sports and Social Development will be able to push through or encourage legislation in this area. Thank you for listening.
Thank you for that thorough presentation. Yes, let's give her a round of applause again, because it's very detailed information about the processes, the legal ramifications of using surrogates. I am going to give a word or two about surrogacy, because I do own an agency that sources surrogates for clinics and patients alike. And I quite agree with everything that she said, but what I have to say, because Dr. Bero already mentioned that I'm going to have a few words about selection of the surrogates, is that the reason why someone like me stepped into the space of recruiting donors and surrogates for clinics and patients is because it's a lot of work, and I do appreciate what the clinics go through. So while I was in the clinical setup, I realized that that's a lot of work for doctors to worry about, sourcing for surrogates and things like that. And I decided if I ever step out of the clinical space, this is what I'm going to do, just because I have the passion to be able to do that aspect of support service for the fertility space. Now, I think the key to selecting a surrogate is selection. Selection, selection, selection. Even if you're going to use a known surrogate, you have to select. You have to know and identify the person that you want to use for this process. Otherwise, you'll hit a stumbling block. And if you're going to use an anonymous surrogate, like most patients prefer, it is also selection. So who is doing this selection? Who is making the determination that these surrogates are actually eligible to go through the process? The fact that you've had 1 or 2 children does not automatically qualify you to be a surrogate. So you do have to be selected, and there's a lot of work that goes in this selection process. I listed it very quickly, and it's about 6. So the selection process is a long one. It can be very frustrating for the potential surrogate, because once they show up, they want you to put them through a cycle immediately and just run them through the cycle so they can start making the money, because the incentive for them is the money. But it's more than that. You have to do basic, quick medical check. You have to do an intensive interview process. You have to emotionally and psychologically assess them. You have to give them a maybe very long questionnaire that they have to fill out. And sometimes most of them give up at that stage, which is fine. That means they're not a good candidate for that process. If you have to go through it, you have to be committed. Blood test is done, their wounds are checked, and they have to sign the informed consent, and the agreement has to be thoroughly explained to them. And of course, like our legal counsel had stated, that counseling is very important. So when you're engaging these people, you have to let them understand what they're really getting into and paint the worst case scenario. So if they want to opt out, they can opt out at that point. And that's what makes everybody go to sleep and rest well at night. And that's all I have to contribute. Thank you. All right, so we're at the tail end of our discussion. So we're going to take Q&As, questions and answers, discussions. I know time is fast spent, but we're just 15 minutes behind. So we'll take some questions this afternoon before we go. So the floor is open. Any questions? Okay.
Good afternoon, all. My name is Abele Onwabwaizu. I serve as the President, Fertility Nurses Association of Nigeria, and I also run an agency for third-party reproduction, as well as serving as a counselor for clients going through fertility treatment. So when the client that gave her testimony was talking, I was asking myself, when is the ideal time to tell a client to stop? Do we think we should have that conversation in AFRH to come up with a guideline on that, when to tell a client to stop? Secondly, is it okay as fertility practitioners to advise clients to go in for adoption? Thank you.
You want to take the, okay.
Thank you for the questions. The first one is, when is the right time to tell the patient to stop? Well, there's no right time really. It absolutely depends on the individual patient and the circumstances surrounding it and on the patient herself. Now, there are some instances where we advise different options of treatment and the patient insists on a particular one, and you keep doing the same thing and it's not working. At that point, I would advise the doctors to put their foot down and say, I think at this point, you should stop because we are not getting any headway because they refuse to take other options. Otherwise, if it's okay to keep trying and to introduce other treatment modalities, as they said, until you achieve a pregnancy, what I have found is people that never give up usually would achieve a pregnancy at some point. And it depends on, usually that's what happens. So if the woman is willing to continue and there are no other things hindering, then it's okay to keep going on, except there's something obvious that you feel would not make the IVF work. Then you need to put your foot down. Like Dr. J had mentioned, there's no time, there are no number is stated as the correct number of times. Some people have done it 12 times, some people have done it 20 before they actually achieved what they want. So it all depends. Now the second question, what was the second question?
Something to do with adoption.
Okay, well, should doctors advise patients? Absolutely. If that is why I brought two patients here to talk about adoption. Usually it seems contrary to what we are doing. However, it is also a treatment option. So I feel it is an option people should think about and should take, especially when things are really getting frustrating. If all the parties involved agree to it, why not? Your child is your child. So that is the way I see it. But you have to be ready to adopt that child. Not just do it for doing sake. I hope that answers your questions. Yeah. Do you want to chip in something about adoption?
Well, sometimes we are not all created equal in terms of our mental and emotional capacity to absorb certain things. So sometimes I guess if as a doctor you can actually see that your patient is not coping well with this, you can, not that adoption is necessarily an easier option, because it's also a long process. But sometimes adoption gives them that break from trying, failing. It can be emotionally exhausting, takes a toll on the marriage and on the relationship of the couple. So sometimes maybe as a doctor, if you see that your patients they're not coping well with this, you may tell them either to take a break or do you want to consider adoption, not because it's necessarily easier, but it's less of an emotional trauma or mental trauma.
All right, thank you very much. Any more questions? Did I see someone raising their hand towards the back? Questions? I think there's a question on the chat. Let me just put on my glasses real quick. Online question. What toll does repeated IVF take on the body, medically speaking? Does it take a toll? What toll?
Well, absolutely. It's something that takes out of you in many dimensions. It takes away. It's like a roller coaster, a lot of people say. It takes away financially, emotionally, physically. You are taking injections every day. Usually it's more than one injection. That takes a lot out of you. then those hormones also have an effect on your body. You like it or not, it changes your moods. So it does take a lot, but when you are focused on the goal, you are able to take those things. When you are focused and you know what you will get at the end of it, it helps you. It helps you. Now, what toll does it take on your body? Sometimes people have said, and that's a common question patients ask, does it cause cancer? Research has shown that it doesn't, because the drugs are usually short-acting, and we've had people do it even up to 20 times and they don't have cancer. However, there are some people that are prone to some cancers that would ordinarily have the cancers anyway, but the hormones might help hasten the cancer showing up. But generally, they don't do anything to you. They're the same hormones normally that a pregnancy would produce, so it would have the same effects. So that's it.
Thank you. So we all have tendencies to develop one thing or the other, and IVF treatment does not necessarily trigger it, but it can make it worse if we're going through the treatment. So medically, it's safe. Any other question? Questions, patients? Are there patients in the house? Questions?
We have a question online.
Okay.
How do you decide when to opt for surrogacy after several implantation failures?
Meaning after how many cycles? Is that?
Yes. Or when to opt for surrogacy after several implantation failures?
When do we decide? Well, it depends on the individual case. There are some cases that are already bad from the beginning, meaning the uteruses or the wombs are not in a very good condition, but you've tried once. Even after once, you might suggest that they use a surrogate backup, even after the once. And there are some situations where they would need surrogacy anyway, so from the beginning, you will suggest a surrogate. However, there are no numbers really, but like my colleague Dr. J defined repeated implantation failures as having three or more failures. Then, of course, by the time you are getting to at least 3 failures, you might want to consider using a surrogate. Thank you.
Thank you, Ma.
All right, thank you very much. So if we don't have any further questions, we're going to move to the next item on the agenda. And I've just been given an instruction that the panelists will be taking a picture with Dr. Biro by the cake. So, but I see on here that the AFRH president is supposed to give a remark, and I believe he did that already. So that one is check and gone. Okay, so I'll just say congratulations again on behalf of AFRH, since I'm the Secretary General, and we want to make sure this item is taken care of. Congratulations, Ma. So, can we take the pictures now? All right, please step to the cake and... And after the picture, we're going to need Mr. Joe Paul Oga to give the vote of thanks. floor. All right, let's clap for our panelists for a wonderful discussion this afternoon. So, Mr. Joe Paul Oga, are you here, available to give the vote of thanks? Okay. Thank you.
Thank you very much. Good afternoon, everyone. I stand on all existing protocols. I'm very, very delighted to be here today. I've learned so much. And most of all is being in the presence of these great minds who have distinguished themselves in their various fields of endeavors and pursuit. I'm so delighted to be here. So it's in the delight of all this I want to say, on behalf of the scientific committee of the ARC, the Alpha Assisted Reproductive Clinic, who came out to make sure that all these things come to pass today. I want to say a great thank you to the international speakers. Also remember the panelists and all those who have contributed in one way or the other, especially those who have contributed in kind, in cash, and even in kind words, who have made sure that this occasion will see the light of this day. The ACT team, we are very happy with you people. It's a plus to us. Massive gratitude goes to all of you. And we want to say in summary that as you go back, we wish you journey mercies. Thank you very much, and God bless you all.
Thank you all. Just a quick announcement for those people. As part of the celebration, it continues on Sunday. We'll be having a concert at Muson Center. Gospel Thanksgiving concert. If you're interested, please, you can pick up the access card on your way out. And finally, to the moment we've all been waiting for, item 7. So you go table by table. I just want to thank all of you again. We've said thank you to our colleagues. We know that this is economic time. You have spent hours. Some people, thumbs up to some people. Hours. Thank you. To our dear patients, God bless you. God will answer your prayer. I trust you've been greatly encouraged. Thank you all. And then pictures, please, for patients, well-wishers. You take pictures with Dr. Barrow. And to our sponsors, thank you so much. Ferrin, Fitsin, Merck, Idua Pharmacy, Alpha Pharmacy, Mr. Pandi and his crew, God bless you. Cheers.